as clinicians, we know it's not structures that make people well. It's knowledgeable, highly skilled professionals who operate in well-coordinated teams, working with people in the context of their family and community. That's how people get well. And as our CCG era closes and the new epoch of integrated care begins, I think it's always useful to reflect on the past so that the future builds on what's gone well and what needs to be learned, so that we don't have to spend lots of time relearning things that we did badly. So the clinical leadership given by our willing GPs to our CCG has really helped to build multi-professional leadership across our footprint through our practices, our PCNs, our integrated neighbourhood teams, through our acute and mental health services, with our voluntary sector, our local government, social care and public health. And I'm really grateful to the support of our membership, which is of all of our practices, the GPs who have put themselves forward to do this role in really great numbers, which is fantastic, but also the support we have from our practices and the clinicians and the managers in there to allow us to participate, and also the fantastic ideas that have come forward from our membership around what we do in the CCG, not just in it. And I think it's fair to say that when we started out as a CCG, we were planning for integrated care from about as early a point as we could do, really. We really wanted to develop the foundation for integration through strengthening the relationships we had, so that the alliance principles we work to through sharing resources, sharing the risk, could be achieved. And here we are 10 years later with alliances in place and an integrated care system about to start. And we knew that it would take time to develop those relationships. We knew that it would take consistency of leadership and purpose in order to get here, because there's always lots of things that will repeatedly get in the way of trying to do the right thing, which is what we're heading towards. And we created a value set based on patients, the great acronym of patients. Patients first, action orientated, teamwork, integration for best results, equality of opportunity, never overdrawn, and timely and safe services. We regularly use those to test the integrity that we try and bring to this this CCG and the intentions that we try and provide. And there's been lots of things that do try to get in the way, as I said. There's always something more pressing to do than getting on with doing the right thing. There's COVID-19 that comes along and decides to really significantly impact on how and what we do. And we haven't had successes in everything that we've done, plenty of successes to be proud about. But let's face it, we've not made enough change for the better in our mental health and ambulance trusts. And I remember, as a member of the PCT in the transition to CCGs, lots of discussion then about mental health, lots of discussion then about flatlined performance within the ambulance service. We have, though, developed strategies to try and reflect our values. We've worked hard on ensuring our approach to integration being about people, not organisations, so that we can leave a worthwhile legacy. If our legacy is a structure that then gets reformed, then that's not an outcome in my mind. The outcome is the way that we work, how we work, what our purpose is that is about reform rather than reforming of structures. And as we move from a decade of austerity through the worst infectious pandemic that we've had in a century, and now into its next phase, which is the cost of living crisis, we still have the known challenges of an aging and increasingly deprived population remaining ahead of us too. That is going to be the challenge for not just the next 10 years, but the next 30 years. And to that end, we need multi-professional, multi-agency leadership to work hand in glove with our population and our communities if we're going to make any chance of improving people's lives in the circumstances we face. And whatever we want to call it, I would suggest it's the shared endeavour that really needs to be based on what matters to people, not necessarily around the structures. And to do that, we really need to support the talent. We mustn't get in the way of new talent coming forward. We mustn't be suppressive in our approach to that, not get in the way of people being able to emerge and develop the environment, the culture, the good culture that allows talent to thrive. It's never been more important. Without it, we don't have recruitment, we don't have retention, we don't have innovation or creation. So those are my reflections. I hope those reflections that I've shared constitute our efforts to leave a legacy and develop, and we've been developing that culture that fosters the learning through building trusted relationships that can be carried forward. And I hope that will be a legacy that we can all be proud of. Thank you. So let's move into the actual meeting. Apologies for absence. Have we got any particular apologies, Jo, that need to be noted?
We've got apologies from Steve Chicken and Graham Leaf.
Which is a shame that they couldn't be with us on our last one. Graham, who's been through all the PCT years as well as the CCG years and been a great stalwart. Thank you for all the work you've done. On to the minutes of the previous governing body. Are people happy to record those minutes as a true and accurate reflection of the meeting? Does anyone have any issues with them? No, in which case shall we move on to the action log. Got a number of things there. Issue around supply of vaccine, which has been completed. Patient story, an opportunity to link up with regard to a future project launch. Dean, something with UCL. Have you got an update on that?
No, we haven't been able to progress that. Unfortunately, we have spoken to Fanwell about it, but we haven't been able to progress that.
Okay. Doke. So if we can just mark that as unable to progress and complete. The CCG's head of communication offered to showcase the Health Ambassadors programme with regular system briefings. Simon?
Sorry, just coming off mute. Yes, that's work in progress, and we did the first one in the last ICS briefing. Okay,
thank you. So we can mark that as complete. And then Paul, in respect of reporting on procurements and private providers.
Sure. Thanks, Mark. So I did respond to Mr. Dooley and gave him access to our CCG database, which is available to the public. And in fact, that takes us back to 2013, inaugural CCG time. But Mr. Dooley quite correctly said, why can't we have the headline values? So I've had a conversation with my team, and I don't think there's any reason as we move forward, particularly in view of the change legislation coming forward, why we shouldn't publish headline figures of contracts. So I've asked the team to look at that moving forward. But in simple terms, I think if what's beyond the question is there maybe a disproportionate spend on the private sector, I can report, but looking back in 1920, we awarded circa 392k worth of private for the 5-year period. Nothing was awarded in 2021, and circa about 230k was awarded last year for essentially vasectomy and minor surgery. So really, as a fraction really of our overall spend in terms of procurement. But again, moving forward, we'll make sure we publish some of the figures as we move into the ICB. Thank you.
Okay, thank you. And we have previously asked that we look at trying to split out the what do we spend in primary care, community services, mental health as well. And Jane, what's the total spend on an annual basis for the CCG? I've got around 500 to 600 million, or am I adrift?
I think it's slightly higher than that, Mark. If you just bear with me a second, I'll find it in the planning paper, and then I'll put my hand up and let you know.
Have we got Steve Chicken arrived?
We have, thank you, but I'm still having a bit of trouble.
Yeah, well done. Okay, shall we move on to the general update? Ed.
Thank you, Mark, and thanks for such an excellent introduction. It's personally speaking, it's been a real privilege to be part of this organisation, and the thing that gives most satisfaction is the legacy that we've put in place for the future, which is fabulous. But you referenced teamwork, and I just wanted to particularly pay tribute to the core of the team over the 9 years, which has been yourself, Mark, as our lead, but also Imran and Maddie, who have been an absolutely first class leadership team, and I think we've all fed off you and learned a lot from you. So I just wanted to thank the three of you in particular, as well as everyone's efforts too, of course. As you said, we've believed in and we've built integrated care over a long period of time. So the transition to the new arrangements on the 1st of July are therefore more smooth than they may have been in other systems. So we feel very confident about the establishment of the new NHS Suffolk and North East Essex board from the 1st of July. We're just completing the recruitment to the partner members, including the primary care members. And we have one executive post to recruit to, which is the Director of Finance post. And I'm sure we would all want to thank Jane, given this is not only her last CCG board, but potentially also her last board in Suffolk, at least in the short term. So thank you, Jane, for your exemplary leadership of the finance function, both within the organisation and within the system, which has met its commitments all the way through your reign as Director of Finance, which is, I think, says everything, doesn't it? So in terms of the last 3 months, the big focus of the NHS has been in a couple of major areas. So one around elective recovery and waiting lists, and we'll see from our papers today, which Paul will talk to, that waiting times are falling, which is really positive, and we are seeing fewer 1-year waits, and we're close to clearing our 2-year waits too, subject to a very small number of patients waiting for maxillofacial surgery. In terms of urgent and emergency care pressures, we've been a resilient system and part of the country. Many areas have been on OPA 4. We touched upon Opal 4 for a short period of time, but generally we've been Opal 3 and we're now on Opal 2. We've put a lot of focus on ambulance response times and handover delays, and you can see in the pack the comparative data. And we've been doing some work, particularly around the ambulance stack, which we believe is great kind of innovation for the future. In terms of cancer, our provider in the CCG ASNEFT have the third highest volumes of 62-day treatments nationally and have recovered their backlog. So we're very, very proud to see the progress being made in cancer and everyone's leadership there. The biggest issue which Mark raised is the latest CQC report on the Norfolk and Suffolk Foundation Trust, which came out as inadequate again, particularly in the areas of safe, effective and well-led. They visited in 2021 and they will be planning to visit again in the coming months and have made very clear that they do not tolerate inadequate services, nor do we, and we must see significant improvements. So a lot of work underway to ensure that improvements can be demonstrated and felt by the population. Thank you, Mark. That would be my summary.
Thanks, Ed. And any questions for Ed? Just a reflection around the NSFT and really needing to get some consistency of leadership, and that external working with partners is going to be really important, I think, for the way services develop. So I look forward to meeting up with Zoe Bellingham to work through how that looks. I know that she's very, very committed to working in that way, and I hope she'll be given the space and will be able to bring her team into that space as well. Steve.
Yeah, thank you, Mark. I'd just like to very briefly say, as the lay member chair of the FPC, Jane's done a wonderful job in helping the whole group. So I'd like to formally add the FPC's thanks, congratulations, great wishes for things going forward, Jane.
Thank you for that, Steve. Yeah, never overdrawn was in our values. We mulled a lot about whether we should have something financial in our values, and we thought if we don't, we can't hold our own when it comes to providing value for public funds. So never overdrawn was that because of that issue, and also because actually if you're never overdrawn, you don't get told what to do quite so much, and you have freedom to think a little bit more differently as a consequence. And yes, thanks for that stewardship, Jane. Okay, we're going to move on into the patient story, and those of you who are familiar with the governing body will know that we routinely bring patient stories to help hear what is happening in reality, and help us try and stay grounded and practical and thoughtful about patient experience. But as it was the last governing body in public, and that we pride ourselves in trying to be a learning organisation and trying to be one that builds on what's happened in the past, I thought it was an opportunity for us to reflect on the many patient stories that we've had since our inception, and just to hear from people around the governing body about how it has impacted what they do, how they practice, how how they think about patient experience whilst doing their work on a day-to-day basis, and the importance of it, and just to try and find out what really struck people in terms of hearing directly from patients or through their representatives at the governing bodies of the past. So I'd firstly like to thank Lisa and her team for extracting all of the patient stories that we've had, with a little bit around the theme and a bit about the brief outline of what the story was about. And, you know, looking back over the breadth and depth of them, it brings back a lot of memories of some of what we've heard. So I was just going to open it up to the floor about any that really struck people about what they remembered and how it impacted them. So who wants to start? We've got Steve Chicken.
Sorry, it's a bit of a Steve Chicken show at the beginning. Now, promise to shut up afterwards. No, as a lay member, I'm not a clinician in any way. I've found them incredibly useful to give the context to the discussions that we make in terms of the CCG. And I very much welcome this opportunity to feed into the future from that point of view. Reading through your list, Mark, I kind of saw three themes, three boxes, if you will, of the sort of patient story we got. First was the personal experience, that very, very tactical, uber tactical personal experience, both good and bad, of our systems, which I found incredibly educational as a lay member, which is great. And I'm assuming that both the generalist and the very specific clinicians we have around the tables also found it useful in that respect as well, because for generalists, you can't be incredibly expert in everything, so it's useful. For the specific person, it's nice to know, and it's really useful to know what's happening elsewhere. So I see a huge educational plus in that. The only slight negative is that I cannot recall, and please tell me if I got this wrong, anything that was actually new. They tended to be subjects and problems and issues and good things and bad things that we knew about. This just put a very, very personal input into that knowledge. I can't recall anybody going, I'd never heard of that one before. It was the personal addition of the information rather than the absolute surprise. The second box I had was kind of a funding request, supporting an existing request for funding or support. I mean, the Lofty Heights one is the one that really sticks in my mind from that. It was such a good pitch, and I choose my words carefully. It was a good pitch. Some voluntary organisations have very good marketing skills, and some do not. I think we just have to be perhaps a little more equitable towards the ones who do not, who don't have videos, etc. There's still value to that, but maybe holding hands with those who are not such marketing gurus. The third one, and Mark will know exactly which one I'm talking about here, the patient story should not be a continuation of a complaints procedure. If a person comes on having had not the right answer they want from the normal complaints procedure, I really don't think that this is the place where they come on and continue that complaint. Again, I haven't seen one that was a surprise, but the one I'm talking about is about dementia. Yes, when your wife or your mother or somebody has dementia, it is the simply most important thing in your life, and you want to do the best, and of course you do. But out there are people who have mental health issues, who have cancer issues, who have maternity issues. You know, the CCG has to cover everything. And I think these individuals forget that, and I really quite passionately believe that the patient story should not be a continuation of the complaints procedure, if you see what I mean. That's all I wanted to say, and just welcome the opportunity to say that as learning going forward into the new organisation and how that links in with the public, particularly with non-clinicians on the ICB board, etc. going forward. Thank you for the opportunity.
Thank you, Steve. And yes, lots of learning here, Ed, for the ICB. Maddie.
Thank you. And I extend my thanks to Lisa's team as well, because it made me both look back with pride, but also think to the future with purpose as to kind of what's done and what needs to be done. So thank you for that. And thank you for this opportunity, Mark. So what's fascinating is I can actually remember so many of these individuals, the place, the venue that we were at, as we used to be able to do, as we heard their stories, and the power that they held for me personally. And there's just two that I would like to mention. The first was in September 2019, when a trustee of the Witton Youth Partnership came to talk to us about the work that he was doing with young people and families in Witton to provide emergency food during the holidays. And this was supported through some of our funds rested with the Suffolk Community Foundation. And what struck me about this was the outcomes that they're achieving, both in terms of engaging and supporting young people, but also of the need for food and the power of food in every way. And it just made me reflect now, as the cost of living really is affecting so many people, how important this remains in health terms. And I think, for example, in Woodbridge, which is the Interrelated Neighbourhood team that I sponsor, we have identified it as the cost of living and the work with the wider Connect community as one of our three priorities going forward. And I think that says a great deal. And also just to reflect that since then, we have worked with partners to establish the Witton hub and that the importance of that now as a physical building with voluntary sector organisations working from it in our community. And second, I just want to mention, if I may, was a young man who came to Two Rivers in November 2019 and spoke about his experience of having a health check as an individual with a learning disability and the challenges of the pre-check questionnaire and of the check itself. And we have done a lot of work since then with ACE, I think, and I hope to improve that process and some fantastic resources. And we have met the national target for LD health checks this year. But that's 70%. And I recall another meeting, again in Stowmarket, when we said that 70% was not enough. That means that 30% of individuals have not yet had a health check. And we need to keep working to secure the greatest number that we can, as close to everybody as we can. And we need to work on the quality of those health checks. And I know that that's something that Wendy and Lisa are going to work with us to try to ensure. So they were just two, but there really were so many. And thank you on this occasion to everyone that's provided their story to us.
Indeed. Thank you, Maddie. Aisha.
Thank you, Mark. And I think thank you to Lisa's team. I must say there were one or two which were really stuck in my head, but we're looking at that document, just remember all these powerful things that have allowed us to reflect. I think for me, it was when I started later on in November 2018, when we had a school teacher who had really hot stress at work, and she then had a suicide attempt followed by just hopelessness, and then how she received support through well-being, and that changed everything for her. And the treatment, her experiences as an individual, the impact on her job, her life, her personal life, the support through GP, and then changing her throughout and making her work as with voluntary services and with children to help their mental health. And I think that is very important, and it's very relevant to what we are seeing today, every day, in our practices, how trust our NSFT is. And it's important that we learn from patients like her. And if we continue to provide the right support at the right time, we can have these young people working throughout to support others and share their stories. I think it's important that mental health remains a very important focus in our lives and on the ICB board in future as well. I think that would be very important. The other one, it won't be if I don't mention maternity services, Lisa. I heard on the radio today about the complaints on Ipswich and Colchester Trust, but that story was all about positive experience of this first mother in July 2019, how the midwife supported her and how she was able to give hypnobirth and all those positives around it. And it's just that, you know, they are very hardworking people in every services we go to, and it's just we need to focus as well as continue to improve things. So I think that they are the two main ones that struck for me. Mark, thank you.
Thanks, Aisha. And yeah, as Maddie was saying, you know, such an enormous thank you to everyone who was brave enough to come along and tell their story, because, you know, back in the days where we used to be able to do this face to face, being able to meet someone and talk to them before the meeting and you know, show the interest and concern around the story they were bringing is nice for us, but it's so important to help people be able to tell their story well, and I think back and have heard so many well-told stories. I think it would be fair to say. Pete Holloway next, and then we'll have Lisa.
Thanks very much, Mark. And again, thanks to Lisa for preparing that list, and it certainly jogged a lot of memories and powerful memories in my mind. But as I went through the list, I was actually faintly surprised to see that there'd only been 2 cancer patient stories in the last 9 or so 70 meetings that we've done. And my first reaction, well, that perhaps we should have done more of that, and is that it could be interpreted as a reflection on perhaps we don't pay as much importance to cancer services as we should. But then I thought, well, actually, I think it's the opposite, and actually a tribute to the quality of cancer services that we do have locally, as Ed has already alluded to, because a lot of the patient stories are deliberately chosen to illustrate deficiencies in our services and areas where we need to improve. And that's not meant to sound complacent in any way, because I think in cancer we've actually always had patients involved in the design of our services. Co-production to us meant Robert Wise and Rogers and Hammerstein. We've always had co-production in cancer services. I remember, though, the last patient story was very powerful. It was a very intelligent, articulate lady who described her services of surviving pancreatic cancer, and she highlighted areas for improvement, which I think still remain and are pertinent today, particularly around the public, increasing awareness of cancer symptoms in the public, an increased focus on prevention, the need for increased diagnostic access and tools to primary care, and making sure we didn't overlook the psychological effects of living with and beyond cancer. And whilst those problems do remain to some extent, and as everybody is aware, cancer services were severely affected by the pandemic, you know, I did take the opportunity to reflect, and I think whilst there's still a lot of work to do, we actually have made a great deal of progress in the areas that were highlighted, particularly in technological advances in providing point of care testing for GPs. Fit testing is a great example of that, and we've been very lucky enough to be involved in the Grail project in our CCG, which is potentially game-changing. We're working on increasing the amount of diagnostic capacity available through the introduction of the community diagnostic hubs, and locally we've introduced things like cancer navigators and paying much more attention to cancer care reviews in primary care to promote the psychological health of of people that have survived cancer. So, after almost a decade, and personally, I've been involved in primary care and cancer services for that time. It was an opportunity to reflect in the light of that patient experience. We've made progress, but we've still got a good deal of work to do. And looking forward as we move into ICS, as I've said before, we've actually in cancer services been working as an ICS probably for almost 2 years now, and I think it's worked very, very successfully. We've got a great team of both clinical and non-clinical leadership, and I'd like to pay personal tribute to Richard, who provides great leadership, but in a very facilitative way, and lets us as clinicians actually get on and design and transform services. So thank you to Richard, and I look forward to working onwards as we move into an ICS.
Thank you. And then over to Lisa, the beating heart.
Oh, thank you. That was lovely. Lovely tribute to Richard. So like many of you, there's 3 that have stuck with me, the Lofty Heights one, and obviously the commissioning that we did around supporting people that require those services. As Aisha said, the maternity one I've always remembered the mum talking about the power of receiving care, the continuity of care model within the Maple team. That was really impactful. But I think the one the story and experience that is still in my head really were the 2 people that joined us to talk about their experiences of personality disorder and how they had co-produced the personality disorder pathway for us, and particularly the young lady that talked so powerfully about her experience of being an inpatient with a personality disorder and how that should never be the pathway we design for people with personality disorders. And of that, I will never, ever forget her saying her experience of CAMS and how when she needed CAMS service, she was told that she wasn't ill enough, and that in her brain she thought, my God, I must be iller I've got, and I'll never forget that. And, it's with some sorrow that maybe we haven't done enough transformation and supported those people enough, but we certainly around the personality disorder team with Richard's team leading that have set some foundations for improved services, so that they were really impactful on me personally and as a clinician. And just to give you some assurance, thank you, Steve, for your feedback around how we should use patient stories going forward. That's really helpful. Sophie is looking now at how we continue this legacy of great patient stories to the ICB board, and actually how we make sure that they kind of are the ones maybe that bring us things that we haven't seen and we're not aware of, that are triggers, as well as those that demonstrate great co-production and great integrated care. So thank you.
Thanks, Lisa. Lolly, and then Lorna.
Thanks, Mark. Good morning, everyone. The 2 that really stuck out for me, and even without looking at the list, when I immediately thought of these 2, one Maddie already mentioned, the Witten Youth Partnership presentation, and that I feel really was really showing that the wider determinants of health cannot be ignored. We can't just focus on health and do the things the interventions we can make from a health perspective without thinking about all the other things that contribute to the health of that person sitting in front of us. And I felt really proud that we were supporting and showing our commitment to these wider determinants, not just on paper or with a list of alliance objectives or strategies, but actually putting our money where our mouths were by supporting these sorts of ventures. And personally, that definitely made such an impact on me that I took that away and thought, actually, what am I doing in my community to support something like this? And actually, during the pandemic, my local church and community started doing something with Holiday Hunger, running a Holiday Hunger club that I sort of put the fire under our behinds to do. So I feel that really had an impact on me, as you can tell. And the one that Lisa just mentioned is the personality disorder one, which I just. When we often see patients with personality disorder in crisis, and you see them in crisis after crisis after crisis, and you don't really get to hear their stories when things are not quite so, when they're not quite so agitated, and understand the whole story, and being able to hear, especially the young lady's lived experience and how that has influenced the personality disorder business case. And I've just really struck me that why co-production is so crucial, and true co-production, not just sort of consultation. And really, although our mental health services are not yet where we would have liked to leave them as a CCG, I hope that we will continue to encourage and not just encourage, but actively pursue true co-production with people who have lived experience of mental health services.
Thank you, Lolly. And that that impact on personal practice is why we can say that we learn and take our responsibility to always be a work in progress seriously. Lorna, and then Richard, then Paul.
Just as a general thing, I think that the patient story has been fantastic. I think it keeps us grounded and in touch with the grassroots, which is what it's all about. And I think that it's good to have some challenging things. I think that around the cancer, if you've managed to make some changes that have actually had an impact, I think that's great. The personality disorder one's another very powerful thing where, we've got to watch out for any holes that are in the system. And I didn't mind being challenged with the dementia problem. To me, that was a fundamental process problem. It wasn't a complaint around a medical diagnosis. It was a mishap. It was a process complaint, really. And I think that we've got to be able to take that on the chin and try to make some changes. And I don't think that we should. I don't necessarily agree with Steve. I think that we should be able to have those aired. I think that we should be a big enough organisation to say there are some good and bad things. And we heard some fantastic patient stories, and it was absolutely fine to have one that was very negative, actually. I think it reminds us of where we're going and what we have to do.
Yes, and I know we've had discussions, Steve and I, outside of the governing body around this, and I think I do understand where Steve is coming from, and the question is, okay, so where's it going to? And if there's a suggestion that where it's going to could be a better place if we took on board some of the thinking behind it and were able to work differently, then I think that kind of reflection in a patient story is relevant, and I think it could be formative, even though it is really difficult to listen to. And I know Nick Hume says, if you're not feeling uncomfortable when you're listening to a story, then are you going to really take some learning away and make a difference? So be happy with being uncomfortable. I know it's difficult when people say complaints are a gift, but that's the sentiment behind it. It's what are we going to do that's different, and we can really say that we've made a change. Richard.
Thanks, Mark. So I haven't got as long a service as Maddie and Mark, but I've got 7 years in the bank in terms of listening to a range of these stories. And I have to say, there's definitely a range of emotions when you're listening to them. Some you're in absolute awe, some you feel deeply depressed, others absolutely inspire. But I agree with you. I think it's Lorna's comments. I think it's an integral part of how we should be transparent and listening to our local residents. And I say resident rather than patient. I think increasingly we need to hear from local residents and not title them patients. And as we go into the new ICB arrangements, and there still are 3 local alliances rising up, absolutely would be saying we should be hearing from our local residents in all of our main meetings to kind of ground us, as others have said. So many stick out for me. So if you indulge me, I'm not going to go through all, but just a few, just to give you a flavour of my 7 years, I think, journey. Because so many of these. I think there's a couple that really just demonstrates how it's not always the big things and the big changes. Oh. Signals.
Richard's connection gone just as he reached his.
We can see you, Richard. Looks like.
Yeah.
Sorry. Right, that is perfect timing. It's been fine all morning, and the moment I speak, I'm going to blame Mark. Cuts me off with my Wi-Fi connection. So yeah, if you could just enjoy it. I think there's a couple for me that stand out as it's not the big expensive changes that need to be made and that make a demonstrable difference. So one back in 2017 about the patient with Asperger's syndrome, who was talking around all the medical diagnosis and everything else. But actually what she found was the difference was the VCSE sector around the dogs for development, which just never even contemplated. And now as a dog owner, I absolutely get it, because I couldn't be without, as many as you know, my 2 mini Dachshunds. And yes, they are proper dogs before I get the joke. Those kind of things I think make a true difference. And in a similar vein, like Lisa, Lofty Heights, I get what Steve was saying. But equally, again, we're so immersed in hospital discharge and getting it all sorted from the kind of core services that we often forget around some of the life, that's why I say residents, the factors around them that actually need change and we need to support. So that one absolutely sticks out also with some of the images that were portrayed. And I remember sitting next to Lisa. So I remember us absolutely talking around that after the meeting on how we needed to do more to support in that aspect. I think also there's been ones where it's clearly demonstrated we've got a gap in what we do. So in 2017, the motor neurone disease neurology, I know, Mark, you were absolutely passionate about doing, that has led to changes, and it has led to our neuro board being set up for the ICS. It wasn't a core part of our transformation programs back in 2017. I think the one where I was probably 2 that stood out as being most uncomfortable was the Felixstowe MIC. And I think that's in a good way. If you recall, we had a really difficult decision as a board to make around the future of an MIC or an MIU, minor injury unit. And actually, I think even though we thought we'd done a huge amount of co-production, we still were caught out with that as when we had the joint presentation, and we needed to go back and do more. And we got there. I think, it shows you can never do enough of that co-production. You always need to make sure that you're doing it right. And then the final 2 for me are around dementia and mental health. I think you can clearly see it's a big theme. And as others said, and as Ed said at the start, we're nowhere near out where we need to be. We've got our 10-year strategy, and a lot of these presentations have informed that. But again, the 2 particular ones that stick out, again, PD, it just made me feel so in awe, I'll use that word, of the 2 speakers who were so eloquent in terms of describing their journey and how they've been so pleased to have been involved and influenced our strategy around PD and the model that we were looking to implement. And then finally, the more recent one that I think Lorna and Steve have already mentioned is on the dementia story. And although that was incredibly uncomfortable to hear, I think a lot of that resonates with my own family's personal experience, not in this patch, of how we've tried to navigate through services for my grandmother-in-law. But equally, it has impacted already in terms of the fact that between the partnership, we've come together to say we've got to get our act together and having an integrated dementia strategy and approach in a way that we haven't had for the last 3 to 4 years. So that's just a kind of a whistle-stop store through my own experience, I think, over the last 7 years with the stories, but a brilliant part of our agenda, and dare I say, probably one of the best in our agendas.
I won't comment on that one, Richard, seeing as you bring so many papers. Paul, finally.
Yeah, thank you. My tenure has obviously been even shorter than Richard by quite a long mile, but I remember, and Lisa's quite eloquently already pointed out that for me, the personality disorder one was what deeply touched me. And I think it touched me for a number of reasons. I think one, it reminded me what this was all about, which is really important once we get stuck into targets and performance and all those things. But more importantly, I think we should pay tribute, I think, to the courage and bravery of some of the individuals that come forward and are paid to share their vulnerability to improve services. I think we should do everything we can to support that storytelling, and that we can do the pre-care and aftercare of that storytelling. So for me, we have to recognize the bravery of those individuals, and that's what I'm going to say. Thank you.
Thank you, Paul, and thank you everyone for your reflections. My personal ones were around the motor neurone disease, and the vital support that coordinator has been able to provide, and again around the personality disorder, where, do you know what, if you ask somebody what they would help, you might actually find a reason to improve their lives. And I think in the round, we're quite passionate around outcome-based accountability. It's the outcomes that are important, but unless you include the patient experience, or resident experience, that describes the story behind where you are now and why you have to change and how you need to change, we will continue to just plan and do, and we won't get outcomes as a consequence. And that is where co-production has to be much more ubiquitous. We've got to reduce the amount of consultation, and use co-production, and get it right first time, maybe, with changing the way that our services really meet the needs of people through managing what matters to them better than we do now. So without it, I can't see a future for meaningful services for our residents. So long may it last. And Lisa, we're handing that mantle on to you, and I'm sure you'll be taking that forward really well. Thank you. What a great way to start the meeting, and straight into patient and public involvement and experience. Lisa.
Thank you. So this is the 4th quarterly report that you've received that really just details the types of involvement and activity across the alliances, programmes, and also our internal PALs and complaints. You'll remember from the strategy that we brought here, we have an ambition to improve the evaluation and the feedback loop. Once we've talked before about being quite good at co-producing and developing services, not always consistently and not always perfectly, but improved on co-production. But we really need to improve the evaluation and feedback loop. And hopefully you'll notice that they're only small in number, but some of the activity around reviewing effectiveness of services that we are commissioning or transforming. So there is a piece of work to review the effectiveness of the community mental health practitioners that's ongoing. I guess kind of following on from the conversation that we've just had, a big piece of work that the team is doing is developing the next stage of citizen involvement. There is some some new guidance out around public and citizen and communities boards, which we are establishing an ICB forum, which will feed directly into the ICB board. And obviously, as alliances, you are doing a lot of work around establishing your citizen involvement forum. And I guess that's the whole thing around, as we take stories and involvement to the next level, that it has to be through everything we do, and making sure that we always are hearing that narrative as part of the co-production journey. So not just at the ICB board, but through your alliances and neighbourhood teams and the providers that we commission as well. You'll see that the digital engagement platform use is increasing, which is great. We did a soft launch, I think is the official terminology to use. So we didn't massively publicise it. We wanted to make sure that we were learning as we encouraged use, and we have a number of surveys that we are using the platform for. The other key piece of work that we are doing is around our patient safety partners, who will be really important to the ICB board as a check and challenge to us around some of our patient safety work. So really looking forward to working with patient safety partners in the future. Other than that, I'll leave it there, Mark, but happy to take any questions on any of the content if that's appropriate.
Thank you, Lisa. Vanwell.
Thank you, Lisa, and thank you, Chair. Yeah, comprehensive report, and thank you for that, and to the team as well. Some good work happening across. I suppose for me, it's really around how some of the best practice is being shared across the system, and the reason why I pose this is, there will be pockets where some very good things are being done, where teams are saying we are engaging with people from these communities very well, but at the same time we're also being approached by other teams who are saying, how do we go about doing this? And you say, yeah, but it's actually happening somewhere within the system. So I'm just wondering if there's ways that we are capturing not just activity that's happening, but the processes and how people are, learning from that as part of the system.
I think that's a really good challenge, and actually I've got an example of that, Vanwell. So we have a really good maternity equalities board, which I know Aisha and Lolu and yourself, Vanwell, have been part of, where actually I think our clinical midwife was telling me yesterday that there are about 30 different communities represented on that board. And yet I met with Andy from Healthwatch yesterday, and he had no idea that we actually had this, because he was challenging me on the work around equalities in maternity services. So you're right, we need to share it more widely, and we need to talk through some of that best practice. And there may be a role for these new forums as we develop them to be able to do that. I think there's also something about us being working with the programme boards and the alliances around that best practice. What does best practice look like? How do we share those good examples so that we are constantly kind of fertilizing across? I don't think that's the right word, but it's the only word I can think of. So yeah, but I agree. I haven't got the answers, but we definitely need to keep doing that to make sure that everybody has best practice.
Yeah, and Lisa is very embedded in maternity today. If Ed, sorry.
Yeah, I mean, I was just going to build on what Vanwell was saying. Firstly, thank you, Lisa. I think we're now really getting the alignment of the PPI team into the clinical kind of services, which was the vision we wanted to pursue. So that's really great. My point was, as we move into ICB with other providers around the board table, is just the conversation around how we align the PPI teams in the providers with what we're doing through your team specifically. So we kind of get the maximum benefit of that.
Yeah, definitely. And they are a key. They will obviously be on our citizen and communities board, group, committee, whatever we're calling it. But there is something not just about aligning processes, but we've talked a lot, and this is again our ambition, is to not just look at siloed experiences, and the sweet spot in all of this has got to be about, as Richard said, not just having patient stories, but resident people stories. Maybe we should call them people stories, because actually we don't want to continue something where we just look at individual providers. We've got to start the work that we've done, and I think we've done it as a CCG, looking at personality disorder services from primary care through to secondary mental health services. We've got to continue that, but build on it so that we're looking at the entirety of experience.
Thank you. And any other queries? So Lisa, we very much welcome the work. Dean, come on in.
Just quickly. I think sort of relationships and these forums are necessary but not sufficient. So we need to transform that in some sort of population health management outcomes sort of focus, so that we know that the relationships and the activity that we generate, although good intentioned, does lead to sort of a scalable place where we can actually see demonstrable sort of outcomes sort of of it. So that's the only additional comment I would sort of add, because if we keep getting the data that says the outcomes are not improving, we really have to be self-reflective as organizations as to whether what we're doing is actually having sort of impact.
Thank you. And another dog for helping you out there, Dean. Yes, thank you, Lisa. We welcome all of this work. Information is real power, isn't it? And we have lots of information, and so do our residents. And it's about how we bring it together and align it in a very transformational rather than a transactional way that will potentially give this our ability to deliver service a big boost. And so how we support people's, not just their involvement, but their real inclusion is going to be a sort of demonstration that we're either paying lip service to it or we really do value it. And that passion for co-production that we hear from Healthwatch and are really starting to embrace is going to be incredibly important. And from an integrated care academy perspective, all of our partners, including the integrated care system, said that co-production is the most important part, framework through which we want to see the work of the integrated care academy progress. And so, our council, this system, Healthwatch, the university, all want to see this kind of work done in this way to deliver transformation, not transaction, as being vital, seeing the outcomes that we need to have if people's lives are going to be have value added to them as a consequence of the money that we're spending. So thank you for that work, and a continuous work in progress, but great to see it. Thank you. Shall we move on to the research strategy for Suffolk and North East Essex Integrated Care System? Lisa, and I know I saw Claire arrive as well.
Thank you. I am going to hand straight over to Claire because she will do it, present it much better than I will. But I just want to say thank you to Claire for facilitating the workshops that we had on this topic and for supporting us by pulling together the research strategy. So thank you, Claire.
Thank you. So just for those of you that don't know me, I am Claire Sims. I'm the Head of Research Management, Finance and Patient Public Involvement at Norfolk and Waveney CCG, but we have an SLA with the Suffolk CCGs to support their research or your research activity within the CCG and across sort of primary care locality. We work quite closely with the local research network. And as Lisa said, we had a number of stakeholder workshops at the end of last year to try and pull together a research strategy that would take us forward from CCG to the ICB and the ICS to build on the work that's already been happening in the region. And this had representation from our trusts, the CCGs, academic partners, primary care and Health Watch and a number of patient and public volunteers. And it was really, we had quite a lot of engagement, a lot of discussion in the workshops. They went really well, and we sent out some reports following that. And then we've drawn together, or I've drawn together a strategy from the basis of those workshops, which have been reviewed by a number of our patient and public contributors as well. And just before you've got the strategy as a paper, but I just wanted to give you a bit of context. Just to kind of and sort of background. So you may be aware that the CCG itself has a duty to promote research, and this has been translated across to the ICB, and it's been strengthened somewhat in that the ICB will have a duty to not only promote research and innovation and the use of evidence, but it's also expected to support partners within the ICB to do the same, really. CQC use research as a marker of quality in their well-led indicator. And I suppose going back to what you were saying about patient stories, research is really important in improving the health and well-being of patients and of our residents, really. And there's a lot of evidence now that research active organisations have better outcomes for their patients. And as you may be aware from the COVID pandemic, research made a huge contribution in how we have effective treatments and vaccinations for COVID, and in our understanding of the transmission and how COVID affected individuals. And there's still a lot of research into COVID ongoing, but and I think it's also sort of fair to say there's a lot of enthusiasm for research, we had high levels of engagement from participants over the pandemic period, and it's continued at relatively high levels. Certainly within the Eastern region, I don't have figures in front of me for Suffolk at the moment, but within the Eastern region, over 90,000 individuals took part in nationally important research over the last 12 months, which is around 2% of the population. And I think it's talking about the sort of patient stories this morning has also made me sort of reflect on some of the powerful patient stories we've had in research, in terms of we had a Barrett's esophagus screening study happening a couple of years ago that practices in Suffolk took part on, and it was looking to screen patients for Barrett's esophagus and a number of patients were picked up with early stage esophageal cancer that may not have been picked up had they not been engaged in that research. And I think some of the COVID studies that happened in hospitals that identify treatment have been the evidence shows that they've saved millions of lives worldwide because of finding effective treatments that work. And so we've sort of built the strategy following these workshops really to build on the work that's already happening in Suffolk and North East Essex between sort of our academic partners such as the University of Suffolk, but not exclusively, and the trusts and our patients. And obviously co-production is really important in research, and a lot of research won't get funded without being involving our sort of residents and the population in the development of those studies. There was also very sort of strong sense that we needed research to be both meaningful and accessible, there is a lot of work ongoing nationally and within the local research networks to really look at how we can make research accessible to the broader population, and particularly some of those underserved communities which actually research may have sort of the most benefit to those patients. Is how do we make research accessible to all, really, and so there is quite a lot of work in that, and that's one of the aims within the strategy, is really to make research that meaningful, accessible. And we've also tried to make the strategy relatively flexible and adaptable as we move from CCG into an ICB and into an ICS, that it will continue to work for this new sort of environment that we're in. And also we've included a number of outcomes, which are on sort of page 7, really, to say, actually, what are we trying to achieve through this strategy and how are we going to, measure that? And really, that's around building the profile and reputation for research within the Suffolk and North East Essex region, developing and building on those partnerships, and attracting more research and more research funding sort of into the region, as well as empowering individuals to get involved in research and to champion research. And it's not just empowering sort of services and clinicians, it's also patients, to really make research more core business than it currently is, and sort of moving along that sort of trajectory, really. And the strategy really has been taken to all 3 CCG governing bodies, and obviously this is the first one. So really, what we're looking for really is any comments that you've got on it, and also for whether this is something that we can then take forward. So.
Thank you, Claire, and thank you, Lisa. I think we're very cognizant that research promotes and supports learning and change for the better, and that if we can point it at the challenges we have, it can help us solve them rather than create new challenges for us, maybe in terms of adoption. And the strategy has been a great process in terms of being able to bring people from right across our communities who've got skin in the game in this to develop it, and it was a pleasure participating in it, so thank you for that. Richard and then Fanwell.
Thanks, Mark. Thank you, Claire and Lisa. I think it's incredibly timely as we transition towards the new ICB and ICS arrangements to have this in place. I think the strategic aims, as you said, Claire, are open and flexible enough, but clearly measurable, which means if the landscape as we are continues to evolve, I think these will still stand the test. And I'm thinking of that in terms of the context. So, for instance, with the ICS strategy that you opened with the higher ambitions, we're about to embark on a refresh of the strategy. So although I'm personally confident those 8 themes, ambitions, will play a part in the new strategy, clearly the strategy will continue to evolve, and it may be that there's other ambitions, other priorities, other outcomes that we'll be focusing our attention on. So as long as we've got that flexibility, as you described, as how research can then continue to support the new ICS strategy from the transition in July, would be helpful. On number 4, I think word that innovation, just to make a link through to the fact that we also are in the process of thinking through what the role of innovation is within our ICS and ICB, and indeed we've got a workshop this afternoon to start our thinking through that. And obviously research and innovation and strategy are all inextricably linked, so this is again really helpful to have this, because it will help frame and link, I think, to the fact we're probably going to develop some degree of an innovation framework strategy. We haven't quite landed on it, so I think those 2 we just need to make sure are linked as we can. And just a question, I guess, I assume that this will be going into the ICB for sign off, because it sounds like obviously the CCGs are endorsing it, but it's our last meeting. And then if it's going to stand the test of time, we need to ensure that it gets the support of the new arrangements. Otherwise, dare I say, we'd have to go through the loop again, which I don't think we need to, given I think the document is clearly robust. So kind of just some reflections and a question.
Yeah, I mean, I think that's really helpful to have those reflections, and the idea was that if the priorities changed from the ICS perspective, that the strategy wasn't linked to specific priorities, but could be adapted to whatever the priorities were. So that was one of the sort of aims behind it. I think I'll let Lisa talk about the sort of ICB, moving into the ICB.
Thank you. Just to clarify, so Andrew, our medical director, has research in his portfolio, so he'll be leading on research, and he is looking at establishing as one of the subcommittees a research board, with or without innovation. I know that's a discussion that you're having with him. Because there's not just this piece of work, there is other research and it all needs to be pulled together. So the work with the UEA Healthcare Partnership that we're members of, there's lots of research strands that needs to be pulled together, including this piece of work. But definitely he will be driving it as we go forward.
Yes, and the research teams within our big providers and primary care and the Integrated Care Academy and the university. Manuel.
Thank you. Thank you, Claire and Lisa, for that. So research, as everyone has said, I think is a critical, part of telling the local story. More often we react to, national papers and certain things that, we see, sort of coming from, either national reports and sometimes you question whether, that is always reflective of the situation that we have locally. So I think it is important, for us to, speak to local communities, explore sort of, let local information so that we know that, what we are doing is in response to local needs as opposed to, what is just, I suppose when you talk about, partnerships, yes, you've touched on that, but I think there needs to be emphasis on, our communities as equal partners in the process. And what I mean by that is, sometimes for, researchers and academics, producing a paper is the success of the process, whereas for communities, they want to see the change that is coming about as a result of the information that they've given you. So the process doesn't end with them, with the producing of a paper, but it actually, continues to what has changed in my life as a result of what I told you. So I think that loop needs to be clearly sort of, stated in the research. But also, I mean, we've just had, the census, not so long ago. We're still waiting for the results. I think it's a unique opportunity for us to actually get some of the latest information in terms of who's here, what are their issues, because some of the data that we have is an extrapolation of the 2011 census, and I think everyone admits that some of that might not be as relevant as we want it to be. So I think we've got a unique opportunity when the census data comes that we can actually build a true local picture.
Thank you, Manuel. Ed.
Thank you. Hi, Claire. Good to see you again. My question was around sharing of learning and research between systems. So obviously you're involved in the Norfolk system and supporting us really well too in Suffolk. So there's merit in kind of economy, isn't there, and sharing. So is there a good way of systems, counties working together to make sure that we get the learning shared?
Yeah, I mean, I think that is a good point. I mean, certainly from a research in primary care perspective, my sort of the office at Norfolk and Waveney supports primary care research across the whole of the Eastern region between ourselves and the Cambridge office. So there is quite a lot of sharing in terms of working across the network. From a CCG perspective, I think there is, we can look at how we work across the sort of, ICB perspective across the two systems, because I think there is some areas we can work together. So and certainly as part of the local clinical research network, there are already links across the Eastern region in terms of the CRN, the Clinical Research Network Partnership Board, and the trust liaison meetings that I attend that cover the Eastern region. So there's certainly already some links on a very operational level in terms of research, and a lot of the work that's happening with the research network is in different pockets of localities, and sharing that learning across the patch. I think more can potentially be done, but yeah, there is certainly mechanisms in place to help that cross system working.
Thank you.
Thank you. So thank you, Claire. Thank you, Lisa. So we very much welcome this strategy, the inclusion of the innovation. We welcome the ability of this strategy to flex around the needs of the system as defined by whoever's in charge at the time, not just the CCG, but into the ICB. We would like to look at how we ensure inclusion of residents throughout the whole cycle of research. So it's not just about being included at the beginning or included as part of the programme. And finally, how it all links together with our other systems across the region, but also across the country, a sort of transparent learning and sharing between us would be good. So what will happen as a consequence of being able to do this for the better. So we're asked to approve it. I think we're quite happy to approve it. Yeah, don't see anything outside of that. So thank you very much. Thank you, Claire.
Brilliant. Thanks very much.
So continuing the Lisa Nobe show with key working function.
Thank you. And again, I'm going to hand over to our resident expert, Leanne Joyce, who has been doing a huge amount of work on this. And again, we'll be able to articulate it much better than I can. But I do recommend the proposals in the paper. Thank you.
Thank you, Lisa. Appreciate such a nice introduction. Hi, everybody. So yeah, I'm here today to bring a paper to you to get sign off around our proposal around the key worker function for Suffolk, East and West. So the actions that I'm asking you to consider today is supporting the recommendation that the CCG commissions Suffolk County Council to provide the key worker function, and within that a sanction to waive the competitive tendering process. And I'll kind of go through a little bit of detail just to give you the rationale behind that request. So just to give you a really brief bit of background, so the key worker function is a response to the NHS England and NHS Improvement Long-Term Plan commitment by 23-24, children and young people with LD&A will have a key worker, and it will also include those with the most complex needs, and they will also have a designated key worker. This is coming from and is the recommendations made by the Dame Christine Lenihan review. So again, really, really important work, and it's really, really essential that we kind of move and fulfill this function as quickly as possible within our local area. The other thing just to say is that there have been other areas within our region that have started on this journey sooner than us. They have sort of been early adopters, so there has been lots of learning that we've been able to secure and to use as part of our development of our plan for our local area. As you will see within the paper, there is lots of detail around, you know, what our objectives are. It is really key that our young people with learning disabilities and or autism that are at risk of admission to a Tier 4 setting have this function, and it is about challenging us as a system. So this function is not a delivery function, it's a function that very much supports the young person and family to ensure that they are getting all of the services and all of the support that they need within our system, and that function can challenge that where that isn't in place. And I think we'll all agree with all of the work that's going on at the moment and all of our knowledge around the challenges and that our young people are experiencing at the moment in our local system, that this function is really needed and is going to be really welcome. So it kind of interlinks with all of the other elements of the long-term plan recommendations. So it sort of links in with the implementation of care education and treatment reviews. So again, that recommends that every young person that potentially is at risk of admission would have a review to absolutely scrutinise. We are doing everything we can as a system to prevent that young person going into hospital. That is our absolute aim. We do not want young people with LD&A in hospital beds. That's not the best place for them. So anything we can do to put in place to reduce that and stop that happening is really, really positive for us. So again, just going through those recommendations, and again, it's around dynamic support register. So we have a local register that details all of the young people that are currently at most risk within our system, and it's around pulling the system partners together again to look at plans of care and treatment to ensure that we're all working as best we can to support the outcomes for these young people and their families. So the reason that we are suggesting that we use Suffolk County Council as the provider is that we already have the CRIS service, which is the Crisis Help Risk Intervention Service within Suffolk County Council. There are key links and potential opportunities with having those services delivered by one organisation. We also have the opportunity in terms of the timescales. We've got very tight timescales from NHS England around the implementation of this model. And when we've looked at the procurement options, going out to a wider procurement process would be too lengthy and it would take too long for us to put that into place. So it feels like a really logical option for us to go with Suffolk County Council. Like I say, they've got a record of delivering community health services already. They've got the experience and expertise in managing System 1, which is going to be our data system. They've also got experience of delivering an independent arm length service. So they deliver Sendias, which is kind of that independent kind of service delivery model. So again, they've got that experience. And again, it offers attractive terms and conditions for potential applicants. We are already looking at recruitment and we are already getting quite a lot of interest in the recruitment and our kind of plan at the moment. So yeah, that's kind of what I wanted to talk about today, and just looking for your approval of our plans going forward so that we can get on and get this service in place.
Thank you, Leanne. So open to some questions. Any questions immediately? I mean, my own reflection was really around welcoming the aspiration here. I think it is a really important one, and pleased to hear that we've got at least a good starting point in terms of how will this be remunerated and as a career, as a job, and ensuring that it is one that is seen to be valued and commensurate with the incredible responsibility and risk that they as individuals will hold, and often that is with quite low financial reward we normally see. So I do wonder whether the hope that is described in the paper in terms of what the offer is would maybe need to be tested at a future point, around how does it square up to the challenge that they will have in that role, and how quickly can there be some certainty of tenure with uncertainty of funding. You know, it's just not fair, is it, to have an approach for such a key role that essentially is we're just going to try it and see how it goes.
Yeah, I agree, Mark. I think the benefit we've got is that other areas have already sort of tested this approach. So some of the pilot sites have been going sort of for around 18 months. So we have got the benefit of the learning. So that has been really, really, important for us. We've worked really closely with Essex and with Norfolk and Waveney around. They have been some of the pilot sites. So I think what is coming out from the initial kind of pilot sites is that there is some real benefit, and I think we will continue to kind of capture those outcomes for our population. We are going to be thinking very strongly around how we monitor outcomes and impact from this provision, because again we're going to need to evidence that this needs to be a more longer term approach, in addition to commission services. So
okay, thank you for that. So any other questions for Leanne or Lisa on this? So it's asking for our approval. So anyone not? Jane?
Sorry, no, I'm not about to come in and not approve it, but just to clarify, this is a Suffolk-wide provision, Leanne. This is not all for Ipswich and East.
No, this is the Suffolk-wide provision. So I'll be taking it to both governing bodies, but it is just for Suffolk, Ipswich and East and West.
Thank you.
Okay, thank you for that clarity, Jane. So anyone unhappy about an approval? I don't see any hands up, in which case, thank you, Leanne.
Thank you, everybody.
Approve that. Shall we do procurement updates, and then perhaps I can suggest we have a 5-minute break. I know we're a little bit behind, but we can maybe pick up here. Paul, no pressure.
Sure. No, I'll keep it brief, Mark. So I'll take the papers to note, and I'll take it as read. The only couple of things I'll probably pick out of the paper would be the Mental Health Framework Award, and you'll notice that on the relevant page there is a breadth of interest, which I think gives us a really good foundation to develop services further into the future, into the mental health services. So great success, great level of interest across a number of ranges, crisis, children and young people, community learning, disability and autism. So again, a great start to our approach of procuring service in the future. And finally, just to punctuate the awards, I guess. So in terms of the Daytime Wellbeing Hub and sort of a Evening Safe Haven, award to Access Community Trust, and we're hoping to mobilise the service in July this year. So again, the teams are working to make that happen. And then the Suffolk Community Connector, which again was awarded to Anglia Care Trust, and again we're looking to mobilise that in July. So again, the transition work is ongoing at the moment. And I'll stop there, Mark. Everything else is pretty clear in the paper, I think.
Yes, thank you, Paul. So any questions for Paul around those procurements? The mental health ones in particularly great to see the breadth of interest in that, and the aspiration of our voluntary care sector to be included. Richard?
Just on the back of that, Mark, and also we're looking to utilise that more and more over the next year. So it's just to say it's just a start in terms of the particular services Paul's outlined on there.
Thank you, and I know that, or I hope that our colleagues in general practice will really benefit from that particular procurement, with the pressure of workload of mental health at the current time. Okay, so any other questions before we just receive and note that paper? No, so thank you for the succinctness, Paul. I'm going to suggest that we have a break and restart at 5 to 11, if that's okay with everyone. 6 minutes, do your best. Hello, hello everyone, are we there?
Yes, we are.
Well done. So, are we ready to go ahead with the next paper? Jane's there, ready and waiting.
So I am, Mark, but I think if Richard is here, it's probably best for him to go first rather than us jump around too much.
Okay. Okay, are you there, Richard?
Mark, he'll be 2 minutes.
Okay.
Or if it's helpful, Mark, I can do the introductory section while Richard's.
Okay, let's make a start and then do your best to flex and make it happen.
Yeah, thank you. So so we're presenting today the plan for 22-23. When we come on to the finance section, which I'll cover at the end, we'll explain why it's particularly complex this year due to changes in the money that's being allocated, all for the good actually, but also because we're not only approving the plans for the CCGs, but we're also looking at the full year plan, which covers the ICB as well. So for the majority of the paper, other than the budget, when I come on to it, we are concentrating on the full year for the commissioning organisations that start up as the CCG and the ICB. And Richard has beautifully appeared just in time to pick up where we're about to go on the narrative plan. But as it says in the paper, the planning process is made up of a number of different documents. We're presenting 4 elements today: the overall narrative, which is very long and prescribed by the national process, but actually gives you a really good flavour of what's going on across the patch for the year. So we're presenting that, and accompanying that are some technical documents which form the activity and performance plan, the workforce plan, and a financial plan. And you have to see the whole lot together to give you the detail. But effectively, if you want to look at what it is we're doing, the narrative plan is the best part. So hopefully Richard will pick up from there and we'll follow through in the order of the paper.
Thanks, Jane. I'm not sure about that. They're all equally important and beautiful in their own right. Just to add to the context of what Jane's outlined, to give the board some assurance, we have a planning group that I chair that brings together the various internal teams who have been working together actually through the last 3 years as we get our perpetual planning cycle underway. We've got to pause obviously after this one for at least a few months, I'm sure, before the next round. So in terms of the narrative document, as Jane said, it's in Appendix A. So I have to say thank you to Narinder Evans, who's again coordinated this process as a labour of love. I'm not sure she'd quite call it that, but we have got, I think, a robust document that's been quality assured by NHS England. I think, as we just briefly said last time, the main focus areas that the narrative plan focuses on is health inequalities, which, as we all recognise, is a golden thread running through all of our work. But there are specific requirements from NHS England around areas that they want us to focus on. So there's a narrative response from the system related to that. The second one is workforce, which Amanda drives across the system. And there's a separate section that Amanda, I'm sure, will come on to around our workforce planning. But there's a specific narrative around what is our main challenges, risks, opportunities, etc. around workforce. The next one is led by Paul, which is our elective recovery planning. And there's a whole section in there that again, thanks to John Reynolds for his leadership in terms of pulling that together, where we've set out across the system our narrative around how we're going to continue to build back in terms of our recovery of the elective position. There's also a particular focus rightly on cancer, again, which Narinder has driven, setting out across the system how we're going to build back in terms of the big key performance indicators, including including 62-day waits and 28-day faster diagnosis. There's also a section on diagnostics, a company and elective that Paul and I are working on together, including the developments of our community diagnostic centres that we've got in place in one of our 3 alliances, and we're planning in Ipswich and East and West Suffolk. As expected, there's a section on urgent emergency care that Paul and Nicola in his team have driven, which sets out specifically work around discharge, the 2-hour urgent response within community services, the new concept from NHS England around virtual wards, which is something that I think is going to be a key part over the next year of our recovery planning related to UEC, and also not to forget our ambulance and particularly ambulance handover delays, which remains a key challenge. And I'm sure Paul will touch on that in the IPR, Integrated Performance Report, later. So I'll probably leave there. Just to say, as I've said before, it's not exhaustive. Etc. There is a separate mental health plan that we've had to submit, and there is a smaller section on primary care, but it has been a specific document from NHSE this time round on some of the key priorities of recovery that NHSE would like us to focus on. So I think at this point I'm going to hand over to Paul, possibly just on the performance side, and then Amanda if there's any further comments, and then back to Jane on finance.
Thanks, Richard. I'll just pick up. I think you've pretty much covered a lot of it already, to be fair, but I think it's fair to say that when you look at 22-23 around elective recovery in particular, it's extremely prescriptive. So it makes a number of requests. First of all, no 104-week waits after the end of June. So again, the plans sort of articulate that, how that's going to be achieved. There's clearly an ambition that by the end of 2023, which is March, there will be no 78-week waiters. And again, our plans sort of describe how we might get there. It's fair to say that at the moment, our plans are reflecting about 380 patients short, but that doesn't mean the system has stopped working toward achieving that aim and ambition. And in fact, as we are at the moment, we're slightly ahead of our trajectory, looking at the current performance. And then there is a whole sort of a tranche around how we might increase the productivity and activity. And there are lots of description around 110% activity of 1920 baseline, quickly moving to 130% following that the following year, which of course requires improved efficiency, requires the workforce, requires the physical capacity. So again, this plan is really for this year, and more work needs to go on in terms of beyond 2023. The way essentially it's going to be achieved, as I've already mentioned, is clearly focused on efficiency. Mutual aid's formed a big part of what we've done so far to date. And it's interesting to note that as we stand now, which was a surprise to me, we've sort of moved up nearly over 1,000 patients across the system through mutual aid and independent sector, which is quite a significant amount. So again, our plan are heavily laden in that area. And of course, as Richard said, there is a big thread going through, which is about health inequalities and understanding really what our patients waiting a long time on our list, what we should do, particularly things like LD, for learning disability, etc. So again, I think the plan is quite detailed. It's a joint effort, collaborative effort between our partners across the system, and how we might begin to achieve that. But for me, it is the beginning of the journey. We need to be planning for the next 3 years, not just 22-23. Around the urgent care sort of elements, I guess swiftly moving on. Clearly, that's got to be a whole pathway approach, and I think what the narrative starts to describe is that it's about better planned care. It is about population health management. It is about access to services. It is about front door processes and internal front door process within the trust, and the way people or patients are managed. The move towards same day emergency treatment, SDEC, is really quite important. The way we minimise ambulance delays at the front door is really important. The way we mobilise our community services around to our response time and use that to minimise ambulance conversion is really quite important. And as Richard said, virtual ward, which straddles both urgent care and elective recovery, will form a really important part of how we move things forward in the future. That's not to talk about our discharge to assess pathways. Our FRAIR to pathways are getting increasingly important, and again, the narrative describes a lot of that. So it's essentially to try to bring all that together. We have sort of launched, our sort of urgent care emergency committee, which had a second meeting last week to try and move some of that agenda forward. But again, the paper is quite detailed in terms of its narrative. It has to be system and partnership approach, and I hope that's what the paper conveys. And I'll stop there. Thanks, Mark.
Thank you. Thank you all for putting this together. And I know that it's something that's been asked of from the centre, and I know that they have applied the prioritisations that they see, but I can see in the way that it's put together that we're looking at our upstream drivers, we're looking at the use of our long-term strategies and the development that we have got locally of the relationships that are required to drive this plan for being something that is just on paper into action, and I think that's really vitally important for us to see. Any other reflections from others? I've got some others to share, but I'm going to just see, is there anything else that anyone else wanted to contribute? Otherwise, I'll carry on. Amanda.
Yeah, thank you very much, Mark. So really following on what Paul said around joint collaboration, the workforce plan was a true partnership with all of our system players over many months. And what we've ended up with is, I think, a robust, triangulated workforce plan that really sets out our plans and everything for the next year. As we will have seen in the narrative, we are planning an increase in our establishment by around 5%, with a true increase of 2% in total workforce numbers by March of next year. The ambition of our people board at system level remains a one workforce approach, and that will continue to be a key priority as we move forward. There are three main components of that we continually seek to address. One being the support of our current workforce, the belonging to the workforce in terms of health and care, and new ways of working, and also focusing on our future supply line. Another key ambition that sits alongside that one workforce approach is our systemic approach to integrated planning. And as Paul said, we're moving away from an annual cycle of yearly planning to something more sustainable. So through our IP approach, we're looking at a longer term 3 to 5 year planning, but not just focusing on health, but health and social care too. And all of this work is being joined up and worked through with our Integrated Care Academy as a key partner in terms of supporting our ambition through the People Board. So they are the key headlines, Mark, but very happy to take any questions from colleagues.
Okay, thank you, Amanda, and I look forward to helping support that work through the Integrated Care Academy from now, really. I mean, workforce capacity is just such an incredibly important issue to try and resolve, isn't it? With the burnout that we've spoken about at the governing body for several months now is quite acute, and the impact of that is so potentially damaging that workforce capacity has to be a key enabler. Anything particular? In which case, Jane, is it your turn around the financial plan and the budget?
It is, yes, thank you. So what we're presenting today is the opening financial plan and budget for this 3 months that the CCG continues to operate. This is in the context of the overall financial regime for 22-23, which will be picked up by the Integrated Care Board in July. It's particularly complex this year, partly because of that split between CCGs and the ICB, and secondly because the things are still moving around in terms of the overall allocations for the CCGs and ultimately the ICB. So the paper, when it was written a couple of weeks ago, talked about the original allocations given to the CCGs, and Chris Armott, who's kindly written the paper, set out in there a number of pressures and the way that the allocations changed from the previous financial year, most notably that we across the country we saw reductions in the amount of funding given for COVID, both for ourselves as CCGs but to pass on to our wider partners, the end of the hospital discharge programme, and rules around the amounts of money that we were receiving for various uplifts for things. But that original allocation was set, agreed with Treasury back in the autumn, and as we all know through our own household finances, inflation has increased very significantly since that point, and we also know that there was a further wave of COVID which was experienced and had an impact on costs and services in the very beginning of this financial year, March, April, and somewhat into May. So the planning round has been quite protracted insofar as financial plans were pulled together on the basis of those initial allocations, but knowing that the inflation has by far exceeded the original amounts provided and the impact of COVID, we put forward some plans around about 3 or 4 weeks ago, which showed the impact of those. And for the integrated care board bit, the CCG bit, that showed, as you'll see in the pack, a shortfall between the resources provided and the expectation of the resources needed to be spent of around about 18.5 million there. There's lots of detail in the paper about the assumptions behind that, which I'm not going to go through. What I really wanted to tell you is what's happened since then. But for the purposes of the meeting, we need to upload that opening budget for the CCGs, and you can see on the final slide in the section, it sets out how we have put forward an opening budget based on those original allocations. The good news for the CCGs is the way that it works this year, the way that it will technically work is that this expenditure made by the CCGs will be matched by allocation, and the allocation that's left will then fall to the CCG, fall into the ICB. So effectively, the CCG bit will always be balanced. But obviously, if the CCG spends more than a share of the resources, obviously that causes a knock-on impact to the ICB. So when we're showing the opening budgets, you can see that what we've shown is balanced parts for the CCGs for the first part of the year, which is what I'm asking you to approve as an opening position today, so that we can get it uploaded. And then as per the paper, it's showing that there will be a shortfall in the ICB for the second part of the year to the tune of 18.5 million. So that's where the paper stops. But where the story has continued, which is good news to present today, is that there has been further work at the Department of Health and Social Care looking at what additional resources might be available to recognise, in particular, the costs of excess inflation and the non-recurrent costs of the wave of COVID. So we received very late in the year, last week, some notification that some additional resources will be coming to Suffolk and North East Essex. I don't think they will be sufficient. So we're working through the detail of those. They won't be sufficient to close all of the gap, but it will go a significant way towards that, and we'll be working through with partners over the next few days to understand exactly the rules behind those, how they'll be allocated via ourselves to partners in the system, what bits will be retained by the CCG and ICB, and the expectation will be that through those further efficiency savings, more work within the system, that we work towards creation of an overall balanced financial plan. So good news. I'm sorry it's not the end of the story. I would have liked to have brought the final budget today, but given that it does mean that there's extra resource to reflect those increased pressures, I think it's as good a position as we could have hoped for. Now that obviously leaves us in a slightly not quite finished position. So we do, as a board, have to formally approve our budgets, and whilst we cannot approve things on behalf of the ICB, we can make recommendations so that the ICB, when it starts on 1st of July, can be up and running. So what I'm asking the board to do today is to approve that opening budget position, but also to delegate to the finance committees to do that next step, which is to take those, when we've worked through the details of those extra resources, to look through the way that we assign those within the CCG and ICB elements and the bits that we share out to our partners in the system, and hopefully to be in a position to sign off some full year budgets by the 20th of June, which is obviously too late for too early for the ICB to have formed formally. So if we can delegate to the finance committees, that would help us to just close that governance loop. Now, I appreciate that I've just rattled through that very quickly, and so I will pause and see if there are any questions.
Okay, thank you, Jane. So the discussions and the approvals are for a plan that's got to a particular point that will have to change because there will be an alteration to allocations, which will mean that plans to manage the gap, financial gap, will be different to what they might be here in terms of what we've got to do to close the gap. Okay, so any questions from governing body members? So we talked earlier about the prioritisation, about the upstream work, the long-term strategies. I mean, my personal reflections around older people's services and admission avoidance. You know, I do get the requirement for virtual wards, but virtual wards at the cost of admission avoidance would be missing the point for older people. Particularly as they're probably more susceptible to the 10% nosocomial infection rates that come with hospital admission and to deconditioning, which of course then impacts their long-term care prospects as well as their recovery. So, you know, virtual wards, fine, admission avoidance, better. In terms of concept of urgent and emergency care for older people. There is a question about promised allocations for the care of older people that have been made by NHS England being substantially curtailed. I don't know if anyone here would know what the potential impact of that would be and whether it's a definite or not, because that could put a bit of a hole in our aspiration generally. Nobody? Okay. Because I do know that we've made quite a commitment within the urgent and emergency care element, the integrated care element for that. So we just have to hope that that proposal that somebody says 2/3 cut potentially doesn't come to pass. Any other questions from governing body members? Okay. So in the context of the expectation of a change in allocation, we're looking to approve this plan with delegation to the finance committees to manage what those changes are when they're worked out and how they will be managed so that by the 20th of June we can do that submission. Is that correct? Yeah. Okay, so anybody not happy with that? Looks like we have approval. Thank you. So shall we go to the integrated performance report? Paul, are you going to start?
Yeah, Thanks, Mark. I'll keep it relatively brief because I think we've trailed a lot of it already, right from Ed's introduction, right to the planning guidance we've just gone through. But I just thought I'd take the opportunity to update some of the figures, maybe, given the fact this report is actually the March report. There has been further movement which the board might actually welcome in terms of information. So absolutely, as we've described it, our performance continues to be framed by the national priorities, as we have been in a level 4 incident for quite some time. But you'll see from the IPR that the breadth of ambition around performance still remains pretty high generally across all of our portfolios. But in terms of elective activity, clearly there is a challenge that we should have no 104-week patients wait beyond the end of June. As we stand at the moment, there are only 32 patients in SNF who are over 104 weeks, 9 of which are oral maxillofacial patients, and I'll come back to those in a minute. SNF continue to be confident that there will be no patients waiting over 104 weeks for that cohort of patients, except for the oral maxillofacial patients. And the reason for that is it's highly specialized. It is originally commissioned. The number of surgeons available to carry out those operations are quite rare, really. But they remain confident that they will have no further of those patients beyond August, and that's a conversation we have in region at the moment in terms of making sure that is delivered. And then beyond that, this is really essentially how the services in future can to be delivered with partnership working with the region. So good news in that sense. The other thing I would add to that is SNF would have moved much more quickly if they hadn't provided mutual aid to West Suffolk, who clearly have a structural issue with their RAC issue. But again, that's enabled us to move very quickly as a system. And if you look at West Suffolk, I think there's about 150 patients now who are waiting for 104 weeks, which is a challenge. But again, working really hard to try and achieve the end of June position. So really a great success given the challenges that we've had across the system, and we're certainly not resting on our laurels, and we are carrying on, making sure we meet that challenge. The other elements is under 78 weeks, and as I've already mentioned, the ambition is to have no 78-week patient waiting beyond March 23. Our current planning demonstrates 380 patients across, and the majority across a number of specialty. Trauma and orthopedics is no great surprise, gynae patient, and big challenge in general surgery. Having said that, we are ahead of trajectory as in the second month, which is great news, and we will carry on working hard to try and meet that ambition as we move forward. I did a look back sort of on Monday to see how we'd achieve some of that, and I was pleasantly surprised to see that we'd sort of moved over 1,000 patients across the system in a variety of ways. Independent sector, mutual aid, organisations, and quite a lot of trauma and orthopedic patients, which has required a lot of mutual working, a lot of joint working, a lot of clinical outcomes working session, which is great news and provides a really good foundation as we move forward into the future and probably three-year plan. We also did put a lot of focus on our inequity of access. And if you remember, several months ago, we had significant and massive gaps between SF and West Suffolk in terms of waiting times around our 92nd percentile of patients. And the report state, I think we've dropped from 11 weeks to 8 weeks, which is great news. But looking back yesterday at the figures that just came out, we're down to 5 weeks differential. So again, that's great news in the sense that we are reducing that inequity of access. In part, it's also due because the West Suffolk theatres are reopening, and they will have an additional theatre as they move forward. So again, additional capacity will be available. But having said all of that, that's early doors really. We need to be planning for the next 3 years at the very least. We had the first of a workshop sort of last week to talk about, so what are the building blocks we need to be thinking about our longer term strategy, which cannot just be about working harder. It has to be how we redesign the systems and elective moving forward, and we will kind of have a few more of those to try and make sure we get full clinical engagement and system engagement around moving and developing our strategy moving forward. So great base to be starting with, lots of challenges. We've made some great advances, but again, our patients are waiting far too long, and we need to be focusing on that to improve the current position. So that's elective activity. I'll quickly move on to urgent care and then happy to answer some further questions. So, as you know, we've been on level 4. As of last week, we dropped to a level 3 national designation. That doesn't mean we're not in an emergency position, but it means that the threat is somewhat lessened. In terms of our COVID patients, which has been a massive sort of challenge, as we currently stand, we have 14 COVID positive patients in Ipswich Hospital, which is significantly less than we have in the past. And across the system, we've got 62 patients, which again seems to have plateaued, but significantly less, causing less operational difficulties than we had before, which is improving on patient flow. As Ed has already alluded to, we had a period of 10 long days where we were on OPAL level 4 as a system, which is unheard of for us, an incredibly difficult period of time. But I'm pleased to report we're now on OPAL level 2. We're one of the few systems that managed to sustain that in the recent weeks, which is great news, and a credit to the hard work and dedication of all our teams across the whole system to try and maintain that. That doesn't mean it's not difficult, it's incredibly hard still, but it means that we are, if you want, successfully manage some of the pathway flows and issues that we have across the system. And I think the other point that I would make is we've managed to navigate a number of long bank holidays, which is no mean feat when you start thinking that there are reduced services across those periods of time. And we are working on the Jubilee Bank Holiday weekend as we speak to make sure we have an equally fair transition through that period. So again, a big credit to the hard work of all the teams that are maintaining the patient safety where we can. Ambulance services, as Richard has already said, remains a concern. If you look at C1 and C2 performance, it's way off where we would expect it to be. I notice it's been a long-term issue, but actually it's been particularly acute for the COVID period for a number of reasons. In part, workforce has been a significant issue. In part, capacity has been another issues, and it has been a challenged organisation as well. So a lot of things happening in the East ambulance service in terms of performance. The way as a system we've tried to support that is through a number of things. We've tried to minimise ambulance delays at the front door, and whilst you'll notice there are some lost hours in the report, we fare pretty well as a system compared to other systems. But again, the trusts are focusing very much on to how they can escalate at the front door and carry on minimising those waits at the front door to be able to release ambulances as quickly as possible. And I think the other point to make is to say that we are working with these to try and make sure that those patients are currently waiting to be assessed, so that we are working with the system to try and support them by utilising some of our urgent care response. So to our response community teams, primary care, GP Federation, are all participating to make sure that we try and hive off some of the patients that can be managed by us as a system, as opposed to waiting for an ambulance to try and improve that position. And I think personally, we can go further than that, and we're having ongoing conversation how we might establish that on a more permanent basis. So I think the only other couple of points to make is we are now seeing an improvement in performance at the front doors. We've had a few days where we've had performance in the upper 80% performance, which is not where we'd like it to be, but certainly is a vast improvement on the 60-70% we've been seeing of recent weeks. So again, some green shoots in terms of the performance of some of the hard work that has been going on at the moment. And then finally, our ongoing partnership working with our local authority, Pathway 1, discharge patient flows, discharge to assess, are all focuses that we are trying to address. So it remains very difficult, very challenging, but we are starting to see some improvement in the system. So I'll pause there, Mark. Happy to try and answer any questions on those two areas. Thank you.
Thank you, Paul. Any hands up? I just wanted to highlight some of the stroke service troubles that we've got within the system, more specifically within Ipswich Hospital, with their SNAP rating having fallen to a D, which is quite a substantial fall. We've had really quite good performing stroke services from a SNAP perspective for a number of years, and I know that there are some specific issues around, some of which were COVID related, and trying to re-engineer the ward space and the access to the ward and repositioning of the gym. But the there has been an impact on the ability to service patients effectively there, and I'm wondering what more we can do to support the trust with that. I wonder whether there's a quality thing, Lisa, around maybe having to, or offering a visit and going in and looking at the pathway from presentation to admission.
Definitely, and I'm happy to speak to Victoria, who's my deputy that works across the urgent elective care pathways around that. It potentially could be helpful to look at West as well, because they also are having some significant workforce issues in their on their stroke ward, and are looking at some changes to workforce and careers and within stroke. So I've written it down. I've made a note. I'll speak to Victoria. Thank you.
Thank you. I have often wondered and challenged the three teams, because I chair the ICS stroke board, to consider themselves as one team working across 3 units, and rather than robbing each other of their staff, is there a way that they could support recruitment through, how they could be deployed differently and managed differently? The stock response is no, but trying to scratch at a rationale behind that, I think we get a whole load of assumptions rather than necessarily true. Paul?
Yeah, Mark, it was just really enough to work with Lisa, really, to some degree. I'm not sure how much the COVID factor and the workforce factor has impacted on that performance, particularly on patient flow within the hospital itself and access to diagnostics. So it's only a couple of weeks ago where we'd basically got 110 on 20 beds out of the equation, so that will cause some significant operational difficulties. So I guess it's also about understanding to what degree that's impacted, to what degree can we return back to BAU, and then your point to say how can we take it to the next level in terms of performance and pathway redesign and conversation. So I can work with Lisa on that. That's absolutely fine.
Okay, thank you. And of course the link between C2 ambulance response and the ability to provide the optimized care pathway for not only stroke patients but for patients who are having a heart attack. Actually, that hour matters, and is the difference between a permanent disability and one that is reversible. So, really important that we try and look at how can we get patients who are in trouble with those signs into the place where we can know what we have to do at the earliest opportunity. I've got one other question around performance, just a reflection from some colleagues in the mid-Suffolk area of our patch who have been getting referrals bounced back from our West Suffolk colleagues saying, you're an East Suffolk practice, you have to refer your patients to Ipswich. And we've been hearing that. Not a great boding well for integration of services and patient choice, particularly patients who in the mid-Suffolk area, about 40% of them choose to go to West Suffolk Hospital. So just for us to keep our ears open for anything around that, because I personally don't see it as a commissioning success if that's the response that we can get. Paul?
Mark, if you'd like to let me have the detail, I'll follow that through. Thank you.
Thank you. Okay, any other questions for Paul? In which case, is it the Lisa Nobe show for quality?
Thank you. I will just pull out some highlights. So I'll I will start with our mental health provider, NSFT. As Ed said in his introduction, this is the first time at public governing body we will discuss the CQC report that's now published, and CQC have rated NSFT as inadequate, and they have served them with a Section 29 warning notice with 109 must-do actions. We believe that the re-inspection revisit will be within 5 to 6 months, and as Ed said at that point, if CQC does not feel that the trust has taken sufficient action to safeguard patients, they could take further enforcement actions, including issuing a Section 31, which would then be an enforcement action. So if you look at the report, you will find that they found some areas of improvement. There were some areas noted around staff understanding the vision clearer, and some staff culture improvements, and certainly our LD services in Suffolk, we have seen some massively significant improvements with services for people with learning disabilities, but there were more areas where deterioration was noted, although the report obviously covers both Suffolk and Norfolk, and it's quite difficult to understand in the report whether the references are made to Suffolk or Norfolk provision. But as an overall, the trust was rated as inadequate for safety, effectiveness and well led, which was a decrease in ratings for the trust. It requires improvement for responsiveness, which is the same as previous inspections, and good for caring, which again is the same in previous inspections. The CQC recommended that the trust remained in category 4 of the system oversight framework, which is the recovery support programme for our NHS trusts that are facing the toughest challenges. So oversight and intensive support is being led by NHSEI, with obviously our support as local commissioners and stakeholders. The improvement plan we're hoping will be shared with us imminently, and it is focusing on safety, the service offer, demand and capacity, culture and engagement, and governance and leadership, with SROs from each executive team leading that work. The improvement board, which was set up by NSFT, which has CCG representation from Suffolk and Norfolk and Waveney, will oversee the improvement plan once it is received. And we have a quality summit today, which is chaired by NHSEI, which we will receive more detail around the improvement plan and have an opportunity to discuss further issues. I think not to dwell on it, but it's possibly just important to acknowledge that there has been some media over the weekend around mortality within the trust, and again that will be an issue that is discussed today. The publication was over the weekend, but obviously as commissioners we will want to understand that and understand what the data is showing. Moving on to the ambulance trust, Paul obviously talked a lot about the ambulance trust. Actually, we've seen a reduction in serious incidents reported by the trust in the last 8 weeks. We've only seen one serious incident reported as a result of system delays, and that was in the Mid and South Essex area. So that has been an improvement, that reported incidents of serious or catastrophic harm has decreased. And again, just for transparency, you may have seen that there has been an incident reported and media coverage relating to a misuse of social media, which I am overseeing. The East response to with the Director of Nursing and through the Oversight and Support meeting again, NHSEI, with NHSEI's support. Moving on, I think my team, particularly IPC, we obviously have reported incidents nationally of monkeypox, but I'm blessed with an excellent Associate Director of IPC who's been doing a huge amount of work looking at our infection control data and has developed a really robust work plan. And I think just our initial thoughts are that we need to get back to BAU with IPC. Our COVID numbers have reduced, but certainly we can see some consequence in our C. difficile numbers and our MRSA numbers around change in focus, and we are requesting some improvements in the post-infection review process for other infections. So really having a big focus on infection prevention and control as we see COVID numbers improving through our providers. I just wanted to highlight two things from our programme, the programmes that I oversee. So firstly, LD&A, I just wanted to raise with the board that our Transforming Care Partnership in Suffolk has the role of host commissioner for a rehab unit in west of Suffolk, and we have previously raised some concerns with our West Suffolk CCG, but as the Transforming Care Pathway is Suffolk, I feel like I just wanted to alert the governing body to a CQC report that has been published for the Elysium Chimneys rehab unit in West Suffolk, which has been rated as inadequate for safety. So we did a quality visit with the national team on Friday, and we will be looking within our host commissioner role. We have no commissioned Suffolk patients in that facility, but as host commissioner, we have a responsibility for safe and wellbeing reviews. So we are working with the national and regional teams around ensuring that people are safe in that environment. Maternity. There's obviously the programme dashboard. I rarely talk about maternity. Well, I do talk a lot about maternity, but I rarely give an update on maternity. And I just wanted you to note really the huge pieces of work that's happening. They have 38 projects, the maternity team, that they are working on. We're just finalising the strategy, which has been developed and co-produced with MVP, our Health Watch Suffolk colleagues have been incredibly supportive, and we have used feedback from a previous survey that they had done around maternity experiences that pregnant people and families had. So we're just finalising the strategy, hopefully to take through to the ICS boards next month. We have Terry is pretty much almost entirely focused on our inequalities 5-year plan, doing loads of work with communities and lots of pieces of work on the inequalities agenda. We have, as a maternity board, commissioned a board review. Tricordant are supporting us around looking at whether we can be more effective, how we operate as a unitary board, and just kind of defining our roles and responsibilities within the board a little clearer. We have just appointed a digital lead and who is going to support us with scoping our maternity digital strategy with Kate Walker's support. Ockenden 2 benchmarking is obviously massive for us, and we've just done the Ockenden assurance visit at West Suffolk, which was very positive. We have the Ockenden assurance visit at ESNEFT over the next few weeks. And the last thing, just to say that we commissioned 8 voluntary sector partners to work with some of our communities that required a different approach, either due to diversity or deprivation, and that's going amazingly well. So we will be looking as part of our funding going forward on how we can continue that work. So lots and lots and lots of stuff happening within maternity. Thank you. I'll leave it there.
Thanks, Lisa. So, colleagues, Imran, I was going to ask if you wanted to come in around mental health, but you might have something else as well.
Yeah, I can come in on the mental health bit. So the Thursday evening clinicians group is developing quite nicely, and we had Andrew Kelso at the last meeting, and we've given him some clear asks, and I think he's going back to some of the system partners to look at how the mental health collaborative boards and the clinical groups and everything all start to come together, and so we can really kind of bring the clinicians and the management teams together, and so we can really start getting into some more of the depth and it's probably fair to say help some of the apathy potentially that's been there amongst some of the clinical teams within the mental health services. So I think it's a really good step, and we've got some really good leaders in that space. So yeah, watch this space. We know we need a lot of support from Richard, Paul and Ed and co just to really get those teams together and working. So we've got a plan for perhaps a workshop or two between the two groups to start to bring things together. So looking forward to that. And Lisa, my question specifically was around the example that you've given of using some of the community partners and groups to support some of the maternity work. And just remind everyone of the one of the what are we missing outcomes that came around, which was around co-production and using our communities. And a thought that we'd had around creating a kind of co-production board where that resource is almost there on tap and can be supported and can be representative and bring others in as well. And just wondering how far that had gone in either the quality space or the sort of community engagement comms space.
So I might kind of shout out to Aisha and Lolu to help me with this, because I know that they are key members of the Equalities Board, and I don't know whether they would feel that it's a true co-production board. I think that we co-produce. I mean, our two main partners that we do a lot of our co-production work with is Maternity Voices Partnership and Healthwatch, but we had a long discussion yesterday about the fact that Maternity Voices Partnership isn't representative of the communities that experience maternity services. So the Inequalities Board will look to, it has 30 different groups, I believe, that sit on the board. We'll be looking to co-produce our services, but I'm not entirely sure of its readiness to do that as yet. I don't know, Aisha or Lolu, whether there's anything you want to add, because you sit on the board.
I feel, Lisa, I think we can see things are coming together, but it's not at a stage where we can comfortably say that it's been co-produced with that minority population. So I think we will probably see it in next 6 to 12 months that is coming together. A lot of work has happened locally in Ipswich with Roma population. A lot of work has happened in isolation in Clacton and other places. So I think bringing all together, involving the VCSEs, I think we were involved in those bids. So we know which VCSEs are going to come forward and work. So yeah, I think Imran has got another question around this. Maybe I said something wrong.
No. I mean, that's a really good example. The question is, how are we going to develop this into that vision of a community co-production board? Because I think it's really important if we're really talking about truly co-producing from end to end. And I'm also just reminded of there was an appendage to one of the papers, Lisa, where we talked about the EQIA assessment process and the checklist. And, you know, I have very strong views on checklists because it's all great, but we can all tick boxes and make things happen. But actually, who's actually going to challenge the fact that an EQIA has been produced? Because we've seen it in the past, haven't we? We've seen things come through that actually don't, manage and actually widen those gaps. So, again, it's kind of a plug, if you like, for this community co-production board to be starting to develop and to be embedded and to be frankly supported and funded by the system, because actually, you know, we know what the commuters have asked. They've said, yes, we want to do this, but we can't be pulled in 50 different directions. If we have a structure and we have a support for them, that's where we get our win.
So, Imran, your point is noted, and I'm sure the board will actually take it forward. I know there's a consultant they wanted to come into the board as well. With obviously my role coming to an end on 30th of June, I just hope that it actually is how things are. We want it to be, that co-production is the key. So hopefully that will happen. Thank you.
Thank you. Dean. Sorry, we're struggling to hear you, Dean. You've managed to get on mute.
A signal.
Okay, sorry, we're not able to hear what you have to say, Dean. Sorry. While we're waiting to see if Dean can organise things, I've just got a question about, you know, what we've got a quality summit. We've got a quality summit on mental health. Are we going to be taking or bringing stuff into that, or are we just going to be hearing what someone else has got to say? And you know, what about the confidence in the leadership? You know, the mental health service leadership, our ambulance leadership. You know, are you confident, Lisa, that the reduction in SIs is because there is a reduction, or is it because they're just not reporting?
That's always the $1 million question, isn't it? Around SIs, usually you can triangulate that through other information that you get, which I haven't seen, but I that's always, you know, reduction in complaints and reduction in incidents, you're right, doesn't necessarily mean that you're seeing a reduced level of incidents, but it seems to be coupled with some improvement in performance with the East. So but obviously we'll keep an eye on that. For the Quality Summit, the process is that it's where the CQC will present their report and their concerns. The trust then has the response around their improvement plan, which they will be asking stakeholders for feedback and to approve. But as a system, we have been asked to also describe some of the risks that we have around our local clinical risks, and I think the points that you've raised are captured within that. There is something about obviously leadership capacity and ability to work and to make improvements both strategically within our collaboration as we move forward, but also operationally with the level of improvement required. And some other significant risks that we have raised around safety for our population and the local population and stakeholders' confidence in NSFT's ability to improve at the speed required.
Thank you. Dean.
Yes, hopefully you can hear me now. Yes, two questions, similar themes. And it's all about what will be different this time, both in the mental health and in the inequality space. It just occurs to me that we keep getting stuck in the P of the PDSA phase. So we do a bit of planning, we do some projects, we do quite a lot of pilots and engagement. but then we get stuck in not defining outcomes in terms of how will we know that these 38 community groups and the co-production is working. So sort of what are the outcomes we are measuring with respect to this, or is this sort of a knee-jerk engagement and placation sort of process? How would we know that this is working? Is it just a case of making sure that all those 38 groups feel that they are happy? Or is there something measurable that we will know that in 6 months our activity, our pieces of work which we want to showcase are actually impactful and effective? And again, similar themes around sort of NSFT, in that we unfortunately have heard the this sort of cycle of crisis, bad report, engagement, system working and co-partnership. But in terms of how will we know, except for the review by CQC in 5 months' time, that we are heading in the right direction, or are we just more and more pieces of work?
So, starting with maternity, and again, Aisha, you're on the board. So, is it placation? I don't think it is. I don't sit on the board, but I don't feel that. Doesn't feel like it's just being done to tick a box. The outcomes is a really important point. So we're looking at how we measure our outcomes. So we have a dashboard of safety outcomes, and we would like to. We're working with Anna Crisp to look at how we understand those through a population health management process, as well as understand our data from a diversity process. So that is underway. There's a huge amount of work that the feedback from those groups have fed into our training and development for staff, our desire to recruit a more diverse workforce within maternity services, and lots of other things. But Aisha, it's possibly more objective if it comes from you rather than me.
I think I can understand Dean's point, but I think we can. When we're working with our current midwives and the board, the aim is not a tick box. We genuinely want to make sure that the wider populations all demographics are involved. And that is what's happening, Dean. But I think the results, it will be few more months, like I said before, because this work has started more actively in last 6 months. And unfortunately, because of the workforce crisis in midwifery and in the hospital and primary care, it has not progressed at the same level as we would want to be, because everyone has not had enough time, but they are genuinely working on it rather than just thinking we have to just tick a box and health inequalities and all done. So I'm confident that we'll see the results in next few months, and we will hear it from our patients, and you'll hear it from your patient population within your practice as well, the pregnant females. I don't know how many actually you see who've actually complained about not being able to receive services they would want it to be. I'm happy to take any questions on that.
Can I just quickly sort of come back, if that's okay, Mark? The only thing is that at the planning phase, it's critically important that we understand what we are aiming for. And I think just a focus on planning around the granularity of outcomes sort of would be critically important. If it's just experiential and qualitative and complaints, then that's just planning for crisis outcomes as opposed to OKRs, and how we know we are incrementally progressing towards the right sort of destination. I just want us to move away from that CQC bad report, complaints, front of the newspaper type outcomes, as opposed to something that we can millimetre by millimetre measure.
Yeah, and I mean, I completely agree. This isn't just about experience and making sure that we've got the right signage and the right leaflets in different languages. That's important, but this isn't just about that. This is about, so Aisha referred to our Roma advocate that works in Ipswich, and since she started working with pregnant people and families, we haven't had a preterm birth within the Roma community. Now that could be coincidence, but there is I agree, we have to track the impact on safety and outcomes. That's really what the work should fundamentally
and
be
I think
about.
it's just not a preterm birth, Lisa. It's engaging with the maternity from the very beginning. Previously, we had Romanian pregnant ladies come to the practice when they were 28-week pregnant. Now they are picked up very early on. They have proper antenatal care, and that is all contributing to good start of the child when they're born. So I think there are lots of positives happening. I think maybe we're not sharing the good stories as much.
I mean, what I'm hearing is that actually the use of outcomes through outcome based accountability methodology, which is what we are trying to get adopted as a common methodology within this ICS, is vital, because it sets the outcomes, it helps to get a baseline, and it gets people involved in understanding the story behind the baseline, which is not just clinicians or practitioners or managers, it's about people and their experience and what is going on. And without understanding that at the start of a plan, the plan will just continue to deliver the same outcomes that it always, or outputs that it always did, and the outcome that's delivered doesn't change. So the importance of information, experiential and qualitative and quantitative, the use of that data, the use of the knowledge of our professionals and the knowledge and experience of our residents is going to be the only way that we will be able to do this coherently, but would offer us an opportunity to do it right first time, rather than just repeatedly go around the buoy and not making the changes that we need to see. So I hope that that's what we will be taking forward. Again, I think I might have that marked against my name for the next few years, but I would certainly be wishing to support that methodology. I'm going to move us on, otherwise we can spend the rest of the day here, I think, talking about these quality outcomes. So Richard, transformation.
Thanks, Mark. I'll take the report as read, and I thought I'd slightly go rogue and just set out some bigger strategic pieces that are happening as we move and transition towards the new ICB arrangement that colleagues might be interested in. So these aren't any particular order, but they relate specifically, wholly or in part, to Ipswich and East Suffolk. So the first one, and we link back to the research strategy, is we're going to be starting thinking around the ICS strategy refresh that we've got to have a draft off by December, which sounds ages away, but actually is not that long if we're going to properly co-produce excuse me, our approach. Now, I don't think we'll be throwing everything out. Colleagues hopefully be glad excuse me, to know and to see, but actually we do need to relook at what our priorities might be. The second one, to give the board some confidence, is that we are in the process of finalising our 22-23 change programmes. I'm deliberately saying change rather than transformation. So we hope by the end of June to have the clear charters and the programme plans in place, excuse me, so that we can be clear on what the outcomes are that we're seeking to achieve. Sorry, I don't know why my voice is just suddenly going. The next area is related to intelligence function and our population health management data set. So Mark and I are sponsoring 2 options proposals at the moment relating to the possible development of an intelligence function for the ICS, which effectively is, in old parlance, in part business intelligence, but it's much broader than that, really around how can we actually as a system support operational, clinical and performance strategy over the years with more of a proactive approach to that. And the second area is around having one linked data set across the ICS that supports our population health management approach. We're due to bring 2 papers to the ICS board in June, which sets out our recommendations around both of those pieces, and then we'll obviously be looking to take those forward in earnest. There's already been some discussion this morning around mental health. As part of that, we are looking to develop a mental health collaborative for Suffolk, which is more than just actually a nice arrangement between partners. It actually starts to think through what an actual collaborative could look and do, which means the current partners we've been talking to, including our physical and community health trusts, our mental health trust, our county council, the voluntary care and social enterprise sector, and importantly our primary care colleagues through our primary care networks. How can we work in a different way together through implementing our 10-year strategy, which could mean service changes in relation to what we currently commission. The next one linked to that is we're in the process of developing our business case for CAM services for Suffolk. So what's the next stage, 2-year plan for implementing our Thrive model related to CAMs that we've signed off before. We've got quite a sizable what's called service development funding from NHS England, which should give us a significant boost to our CAM services within Suffolk. We're also, Pete and I, in the process of redeveloping our ICS cancer strategy that has now run out. So we're looking to redevelop that for the next 5 years, and we've got some support from NHS England through a colleague in the Alliance to support us on that piece of work. And importantly, we're really clear to develop an outcomes dashboard related to the cancer programme, so we absolutely understand, related to the strategy, what we're actually looking to deliver on over the next 5 years. A newish area that I know Ed and colleagues are very keen to start to spearhead is dental. So as colleagues know, dental is coming back to us as a commissioning responsibility from the 1st of April 2023. We have set up a task force that's looking at some more immediate improvements we can make, including urgent access to dental services. We're due to meet with the Toothless Suffolk campaign group in the coming weeks, also to understand from them directly some of the challenges facing our local population and what we can do as a result of that. 3 more related also to the responsibilities that are coming back our way from the 1st of April locally is specialist commissioning. So we're also now looking at what that means in practice, which is a significant and sensitive piece of work, really to look at what are the opportunities, risks, etc. related to that coming back and what that would mean. So I'm your rep on the new specialist commissioning committee that met for the first time last month, which is leading the work in terms of that transition. We're also in the process of, as well as a collaborative development with mental health, we're also supporting our 2 physical acute trusts in Esneft and West Suffolk, looking at the opportunities, risks and benefits for our 2 trusts working more collaboratively. And indeed, we've got a board-to-board session that Ed and I have been invited to on Thursday to look at the first report that's been done, which is following a number of structured interviews among partners, particularly in the trust, clinical and managerial, around what are some of the opportunities around that. So looking forward to that discussion on Thursday. And then finally, just on children's, we've also looking to develop a new 4-year CYP strategic framework for Suffolk, the County of Suffolk, which involves the 2 ICSs and the County Council and all of our different partners in looking at what is our ambitions and the outcomes we're seeking to achieve over the next 4 years related to children's, and then in more detail, what are the opportunities to further integrate across our organisations, including posts, budgets, governance, etc., etc. And there's a similar piece of work that Lisa's sponsoring around LD, learning disabilities and autism. So I think that just gives you a bit of a flavour of some of the kind of strategic change pieces of work that I'm currently focusing on. That's as well as the detail that's in the pack around the progress with our individual projects, which are ongoing.
Thank you, Richard. Any questions? from me, not so much a question, but again an observation around ensuring that all of those charters are clear about their outcomes, and how we do that translation of the work contained in the charters and all the hard work that's gone into creating that into an accountability framework where it's clear what the end game is, and clarity on the measures that demonstrate whether we're heading in the right direction or not. I think will be critical. Any other queries for Richard? But a very ambitious list of things against your name, Richard, to project into on behalf of the integrated care system. So well done for that. In which case, shall we move into the knotty area of finance? Jane.
Yes, thank you. So included in the pack is the financial report for the full year that ended on the 31st of March. We are in the process of preparing, and well, we've prepared, but we're now having audited our financial accounts for the year. So this is the draft position, and I'm really pleased to report to this last meeting of the governing body that we ended the financial year in pretty much a balanced position, a very small surplus of 0.1 million relating to some late received cancer allocations. So very overall, very positive picture. You'll see in the report that that overall the resources that we had to spend in Ipswich and East Suffolk CCG, and I'll give you the particular figure because I know Mark mentioned it earlier, even though I did put it in the chat. We expended £684.3 million pounds to support our population over the year. Just shy of 600 million of that was our recurrent resources, and then there was a range of non-recurrent resources and retrospective top-ups as set out in the paper. The paper goes on to talk about what those retrospective top-ups related to, and if you remember when I was talking through the planning paper, we talked about the hospital discharge programme, which was being enforced during the COVID period to support joint working between social care and the NHS on admission avoidance and discharge. The amounts that we're talking about for there, we claimed 8.3 million as part of that centrally funded scheme last year. And as you can see, that's because that stopped on the 1st of April. That is one of the pressures on achieving a balanced budget as we go forward. But it was extremely helpful to have that extra support, and it really facilitated the already good joint working in that area over the COVID period. The report just sets out where the variances are against the budget that we set. The main areas of pressure are no different from people than I've been reporting for the last few years, particularly around continuing the healthcare and prescribing, some of which has been offset by those central allocations. So I think it's probably best if I leave it there, Chair. But I'm obviously very happy to take any questions.
Thank you, Jane. And landing the aeroplane on the pin of a needle, really, top of a needle, really. Fantastic. Any questions for Jane on that? A lot of relief all round as well. Managing to land on a 0.1 surplus is quite gratifying. Okay, so any more on the integrated performance report? In which case, shall we receive and note that and move on to the governing body assurance framework? Now, Graham isn't here with us. Is Amanda, are you prepared for this one?
I am indeed. Thank you very much, Chair. So happy to give a few headlines. So a lot of the risks contained within our current GBAF, of which we have 16 current live risks, have been addressed throughout the course of this morning's meeting. But I just wanted to highlight a couple of areas pertaining to the ICS white paper risk, which is currently on a level 9. We continue to manage that programme and project of work in a systematic way, and we are on target to smoothly close down this CCG and transition into the ICB from the 1st of July, which is very positive. And we have a further meeting with NHS England regarding that tomorrow. I think Paul's touched on the COVID-19 risk earlier on. We've now reduced that this time from a 4 to a 3. Lisa has eloquently updated on the NSFT risk. And the only other thing, Chair, that I wanted to raise was, as we are in this transitioning period, we are now looking at future reporting for risks for the ICB. Likely we'll end up with one report with each of the 3 alliances having their separate risk register going forward. And our current CCG risk forum will continue to be managing the whole risk agenda as we move forward. So that's really all I wanted to say, Chair, but very happy to take any questions.
Thank you, Amanda. Any questions, Ayesha?
Thank you, Amanda. I think I probably missed it, but I am assuming that workforce is on the GBAF across primary care as well as our secondary services, because we know we're not able to grow our own, and how we're going to work to make sure we have got enough people to sustain the services which we have to provide.
Absolutely, Ayesha. It is contained within, and as you know, is a key priority of our system people board, but also our medical workforce, which Francesca chairs, which I know you're part of. So it's part of the bigger picture in the round, but absolutely, we need to be looking at non-traditional methods of securing our future workforce.
Okay, thank you. And for the sake of those listening in, Amanda, do you want to say what the People Board is?
Absolutely, thank you, Mark. So the People Board basically is a collection of our system leaders across the entire system that come together once every other month to look at the totality workforce agenda, and that then is reported to our Integrated Care System Board, and that will continue as we move into the new agenda, new world.
Thank you. And just one other around opals. Paul, lots of different meanings of opals. A juicy fruit, sweet, or a car, or something that Ayesha would wear on her finger.
So, yeah, Mark, essentially there are 4 levels of escalations, which are known as OPAL, level 1 to 4. Level 4 being the highest level you can be in terms of stress on a system, should we call it. It's backed by a number of definitions, which I'm happy to circulate to the board in terms of the criteria that are applied. But essentially, they take into account pressure at the front door, pressure in the system, pressure on workforce, performance, impact on performance, and level 1 being everything's running as it should be. So if that's helpful, I'll be happy to circulate a brief document that explains all of that. That'd be absolutely fine.
No, that's fine. It's just being sort of understandable, isn't it, in a public arena. So thank you for the GBAF, and we'll probably carry on all the way through to the end with you, Amanda. So we do declarations of interest next.
Brilliant. Thank you very much, Chair. So this is our 6 monthly report where we have to publicly declare all of our conflicts of interest. So they are here for the governing body this morning to note and to consider whether indeed there is any further action that we would like to take, particularly focusing on the non-responders.
Indeed. Okay. Any questions about that? In which case we'll receive a note, we'll review a note, and if those who need to give their declarations, please can. We've got 2 more months to go. Jane?
Thank you very much. You just said what I was going to say, Mark, which was could people please put in their declarations. We are dealing with this as part of the audit, so please don't think that it's not been taken into account somewhere.
Yeah, and it's a professional requirement. It's not just a CCG thing. For any clinicians, it is a part of your professional requirement to do so. So please do that. Shall we move into the National Staff Survey results?
Superb. Thank you very much, Chair. So this is a positive report, and colleagues may have received an update from previous conversations, but in essence, here we have our survey results, which is now in the public domain. It reflects a survey that all of our staff were invited to participate in during October and November of last year. The survey focused on 7 elements of the People Promise and 2 of the themes which we've previously reported on pertaining to staff engagement and RAMAL, and all of those are sectioned in 1.2. And for us as a collective times 3 CCGs, we had roughly a response rate of 66%. And in terms of all of those 9 elements that we were surveyed on, the CCGs scored above average in all areas, which is very good news indeed. And in terms of our best scoring areas, they focused on 3 areas which were above the sector average. And they were, we work flexibly, we are a team, and we are compassionate and inclusive. And our top 5 questions that received a higher than positive score are shown on page 2. Clearly, we know there are areas that we need to be focusing on for further enhancement this year, and they are things like ensuring all of our staff have a PDP, and that's something that we need to strengthen as we move forward. And we also need to ensure that all of our staff have the appropriate kit to enable them to deliver the jobs that they do very well, either at home or in the office. And that's something that we are going to be addressing and indeed have started. The report also shows where we compare against other CCGs in the region, and they are shown towards the section at the end of section 2. And as you can see, our 3 CCGs scored or were the highest ranking area in all domains bar 1. And I think that is really good feedback indeed. I've mentioned further action that we need to be taking, and that's something that we are currently focusing on through a number of OD focus groups that Nick in my team is leading on behalf of the CCG. So all in all, Chair, I would summarise that we've had a very good staff survey results. We've got good above average scores in the majority of domains. We're not complacent. We know where we need to improve, and they are areas that we will be addressing as we move forward.
Great, thank you. And as you say, very pleasing to hear from our own staff about how they feel about the CCG. Anyone want to make any comments? No. Okay, but a good exit feedback. Okay, shall we move on to health and safety?
Thank you very much, Chair. So this is our standard report. We meet as a committee twice a year. The last meeting happened at the end of April, and indeed was the last health and safety meeting of the CCGs before we transition into the ICB. But as the report articulates, we're focusing on getting our officers across all of our locations ready to welcome staff back. So as a continuation of that, and making sure that when staff do return, they come back into a safe working environment. So nothing more to report than we have grip, we have no incidents to report. We continue to work with the wider tenants of the buildings we occupy, and all is positive.
Okay, thank you. And that sort of preparation for the return to, more ubiquitous face-to-face work is important, and and an acknowledgement that being able to work flexibly at the same time as being able to work in a coordinated way is going to be a great aspiration, but it will be a challenge in terms of all of the organisation that will be required to go behind that.
Absolutely, and agile working, Mark, is a key area that we are working through with our staff at the moment. We had 2 focus groups last week. We have further conversations this week with our directors to look at agile working in the whole. So we're moving that forward in a positive way.
Okay, thank you. In which case, shall we move on to the minutes of the meetings? Again, standing in for Graham on that one.
Thank you very much, Chair. So I will take the minutes as read, but very happy to pick up any areas of question or clarification.
Any areas of question? No. In which case, shall we move on to the approval of the Suffolk and North East Essex ICB Constitution?
Thank you very much. So this is a formality. So the journey began last summer when we were issued, along with other systems, a mandated constitution. Work has continued since last summer to this very moment in time, where we have been basically updating our constitution to reflect the ICB. We have been going through robust recruitment processes for executive directors, other directors and partner members. We hope that we conclude that in the next couple of weeks or so. But as a key requirement of our constitution, we have been required to consult, and that consultation has taken place over a number of weeks, particularly focusing on our ICB membership or ICS membership. And we have now collated all of the responses in a kind of you said we did approach. And we have now collated and submitted to NHS England for their ultimate approval. So it's coming to our CCGs today to note and hopefully support the direction of travel.
Yeah, and I've certainly seen this through a number of partner committees. Did anyone have any questions about it? I think it's been generally well received. It's had positive comments, minor suggestions, but in general, happy to approve or to receive and endorse. Yeah, thank you. So we've come to the end of our business. The date and time of future governing body meetings, we don't have any in public. We will have one in a private session, I think, towards the end of our tenure in collaboration with our West Suffolk and North East Essex CCGs. So thank you to everyone on this clinical commissioning group and seeing it right through to the end, and look forward to working with you in different roles from the beginning of July, but still another few weeks to go before the formal end of the CCG, so thank you. We do have only a short few minutes left for questions from the public. Simon?
Yeah, we have 8 questions in total. They all come from Anthony Dooley. The first question, and I read it word for word from Anthony. It's as follows. Now that Mark Shenton has had 2 months to reflect on the first 3 questions that I asked in March, would he care to answer them properly? I'd prefer silence to nonsense. So, for example, can he explain how a virus be managed? That's the first question.
Okay, and I'm hoping that we've answered quite a few of the questions as we've gone through the board today. Simon, I tried to weave them into the process of the board rather than just spend time at the end then having to re-explain what we've already explained. So an interesting question. My response is I don't want to change what I'd written in response to the previous, or what was written into the minutes in response to the question from the last time. I'm not really sure how else to respond to the nature of the question. I've just seen through 27 participants in a fellowship based on integrated care, where what we teach is the nature of trust in the way that we do work. And I found a fantastic definition of trust in an article called The Future of Command and Control, produced by the Army leader, and it describes trust as your integrity and your intent times your knowledge and your ability to deliver results. So having your integrity and intent question when you're in a trust position is quite a challenge, and to have your own particular knowledge challenged as well is quite difficult. But I would direct any questioner around managing a virus to the WHO. They've just released their guidance on managing monkeypox, but there was also significant guidance from WHO in COVID-19. And on that trust piece, the ability to speak up and to have the freedom to speak up is something that is very dear to my heart, and supporting colleagues to speak up when things aren't right is incredibly important. And if we are to ever learn from mistakes, if we are to ever put our hand up and say that we don't know something, or to say that something isn't right, I think I would challenge anybody who told me that I wouldn't have that right in the future. Really being told to either be silent or not to speak nonsense, to me, I'm sorry, I just don't take that on the chin. I would be actively saying, I don't believe that shutting up and not raising my voice or giving an opinion is something that I would be admonishing somebody over. So I'm sorry, Anthony, I don't accept the style in which you have asked your question, but I don't either wish to change my response. So I'm sorry, but that is just not how I would take things on. We now come to the end of the governing body meeting. I'm hoping that the vast majority of those other questions that had been raised in advance have been answered. So I have not got the time to go through them in detail. Aisha.
Mark, I would just like to thank you on the behalf of the governing body members and the panel. I think over the years, since I've been a member since 2017, and I've learned a lot from you, and you're a role model, and anyone questioning your integrity will be questioning ours as well. So I think you're a very honest role model, and I would like to thank you for actually, personally, I've learned a lot from you. And on those words, I think probably this is the last thing I would say in this meeting. Thank you.
Thank you, Aisha. So I'll close the meeting now, and look forward to meeting everyone here in the part 2 imminently. Thank you.